And let's get started. We have 9 speakers today, and so we're gonna keep things moving. I'm Jen Gerber. I'm the lead course organizer and have had support from Omer and Spence, who couldn't make it to this conference. And we have a lot of speakers here for you today. And we're excited to talk to you about a range of topics for vaccine safety and effectiveness. This is an overview of the schedule for today. So you see, we'll start out by talking about effectiveness. We'll have a little 2-minute stretch break, grab some more water, and then we'll move into talking about vaccine safety. After 2 different talks about safety, we're going to have the coffee break, and there'll be coffee upstairs. And then we'll come back here for more on safety and real world data, and then a panel with our panelists who definitely won't fit up here. So I'll be thinking about how to strategize about that. Nearly all of the speakers here today are members of the Vaccine SIG. And if you're interested in learning more about that, we're meeting tomorrow on Friday evening at 7, and you can find the room location in your program book. So without further ado, I will welcome our first speaker to come up here and introduce himself. I didn't put yours down.
Thanks very much. Just call. Okay. So great. Good afternoon, everyone. My name is Morgan Marks. I'm actually a senior director at Moderna, supporting Moderna's COVID vaccine program. So I'm just going to provide just talk to you for a few minutes on just some very high-level overviews of key study designs to evaluate vaccine effectiveness as a setup to, the super interesting talks that will come after me. So I'm an employee of Moderna. I receive salary and stock from the company. So the 2 key questions that I'm going to briefly cover today in the next 8 to 10 minutes is, why measure vaccine effectiveness? Isn't an RCT enough? And what key study designs are used to evaluate effectiveness? So as we all know, randomized clinical trials are the gold standard to use to evaluate safety and efficacy of a vaccine candidate. We know that the randomization process of RCTs and their active follow-up kind of give a real advantage to looking at kind of unbiased estimates of efficacy. However, they're limited, in a number of different capacities, which is why we do effectiveness. First of all is the population that typically, right in my face, typically used in an RCT, tend to be a very select population, right? They're healthier, they tend to be more active, health conscious. And as a result, we can't really look at efficacy and study in subgroups such as immunocompromised or maybe individuals who are at higher risk for the outcome of interest that we're trying to study. In addition, RCTs tend to be limited with regard to racial ethnic diversity. So they're not necessarily a true generalizable cross-section of a population. In addition, they have RCTs are typically powered for specific outcomes, and so they're limited with regard to breadth and scope of other outcomes. So for severe disease or death or things like that, even though RCTs can be large, the number of endpoints that are typically an RCT is powered for is usually pretty focused. So real world effectiveness studies give us some ability to look at other endpoints and outcomes associated with a vaccine of interest. In addition, and I think we've seen this a lot with the COVID vaccine, is that, randomized clinical trials have limited follow-up time. So if we want to look at the performance of a vaccine over a longer period of time, a randomized clinical trial tends to be, a little bit short with regard to follow-up. And also, importantly, the dosing schedule that's followed in an RCT, is very strict, right? And it's followed per protocol. So it may not necessarily be generalizable to real world scenarios. So that being said, effectiveness studies are important complements to RCTs and in fact add a very important dimension to understanding the protective ability of a vaccine in the context of its use in the real world. And I think it goes without saying here, but I'm going to say it anyway, that, the COVID-19 pandemic and also flu before that and currently, has spurred a lot of interest in the use and the value of real world effectiveness studies from regulators, from recommending bodies, NITAGs and such for decisions regarding recommendations and policy decisions. So as a result, regulatory agencies are very keen on looking at vaccine effectiveness studies and requesting vaccine effectiveness studies, particularly as post-authorization commitments on a lot of vaccines. And as a result, I'm sure we're all familiar of the recent draft guidance documents that have came out that have kind of dictated, the use of effectiveness data broadly, but I think have, very, important implication for vaccine research and effectiveness. So that being said, what are some of the key study designs that are used to evaluate effectiveness? So the first is the cohort study design, which I think we're all quite familiar here with. Basically, there's individuals who are eligible. Let me see if I can get the laser pointer up. People see that? Great. So basically, you have individuals who are eligible to receive a vaccine in a real world scenario, and then you have individuals who receive the vaccine. And then you have a suitable comparator. And so those comparators could be individuals who have not received any vaccine, so an unvaccinated comparator. It could be an individual who received another type of vaccine in the realm of kind of comparative effectiveness, or it could be an individual who, much in the way that the COVID vaccines were evaluated, received a primary series, but not an updated booster. So kind of the quote unquote N-1 designs for a comparator. So both of these, exposure groups are then assessed for the outcome of interest. And those outcomes can be identified based on clinical symptoms, laboratory methodologies. The comparators, just to be noted, can be concurrent with those who are vaccinated, but can also be historical in nature. And many studies match their comparators and their vaccinated cohorts in order to control for potential confounding, particularly confounding related to health-seeking behaviors. And then, of course, we know that the exposed and the comparators are followed up for the outcome of interest, and there's censoring that can be conducted, due to death, loss to follow-up, other things like that. And then overall, what the nice thing about the cohort design is that because you're starting with a population that is unvaccinated or a baseline general population, you have the ability to estimate incidence in a more generalizable fashion. And then vaccine effectiveness is typically calculated using, cost proportional hazard models or something of that nature. So I'm just providing an example here of a long-term effectiveness study utilizing a cohort design, which was a study conducted to evaluate the effectiveness of the live zoster vaccine, Zostavax. So this was a prospective cohort study conducted within the Kaiser Permanente Northern California integrated healthcare system. So overall, individuals who are indicated for the vaccine in a real world scenario, so individuals 50 plus years of age who had continual enrollment in the KPNC system, were enrolled. Study entry into this cohort was based upon U.S. approval of this vaccine, which was May 2006 for individuals 60 plus years of age, and in 2011 for individuals 50 to 59 years of age. And basically, these individuals were enrolled. They were enrolled unvaccinated, and then they were followed up and they became vaccinated. That was their exposure of interest. So follow-up time was partitioned, based upon their exposure to the vaccine versus unvaccinated. The exposure of interest here was the occurrence of the outcome of interest, was the occurrence of a herpes zoster or shingles, identified using ICD codes in the healthcare database. So this design was really kind of a nice design to look at long-term effectiveness of individuals who receive the zoster vaccine. And so what I provide here is just an example of, at the top figure here, this is from a paper back in 2018, just kind of the sample sizes that were involved. So you had over 40,000 herpes zoster cases that were identified, over 4-5 million person years of follow-up. So very large numbers, which allowed for a lot of subgroup analyses by age at vaccination, by time since vaccination, by different racial ethnic groups. The Kaiser system is, generally representative of the Northern California population. So there were definitely analyses done by racial ethnic groups of Black and Hispanics. And then another interesting analysis that was conducted here was by immunocompromised status, which in the shingles prevention study, which were the pre-licensure clinical studies, we really couldn't look at immunocompromised, effectiveness in the immunocompromised state. So that's another advantage, I think, of these types of real world studies. So pivoting quickly to the second study design of major study design, which is the test negative study design, which I think we're all very, very familiar with from the COVID world and from the flu world. But this study design kind of flips the model a little bit and starts with individuals who are sick, right? Who seek care with a specific diagnostic criteria, specific signs and symptoms. And then cases and non-cases in this case control design framework are ascertained and ascribed based on laboratory or diagnostic testing for a specific causative pathogen, right? The biggest advantage of this is that you are in some ways controlling for health-seeking behavior, which is a major source of bias in a lot of these real-world studies. And then we look at the odds of vaccination among the cases, and you compare the odds of vaccination in the non-cases. So this figure here on the right, basically I put it up here as an example of how signs and symptoms are identified in different studies. So each row on this figure represents a different study or collection of studies looking at flu and how flu cases were identified in the test negative design setting. And you can see that for the most part, a lot of studies utilized fever, cough, common influenza-like symptoms for their study population definition. But there is a fair degree of heterogeneity. So this is a key important aspect of test negative design when you're thinking about utilizing these types of designs. So just as a very quick example of a recent test negative design study. So this was a study looking at the effectiveness of mRNA COVID vaccines. And this is in the context of the Vision Network, which for those who are, I think, unfamiliar, the Vision Network is a collection of healthcare systems across the U.S., and it's a CDC-sponsored, U.S. CDC-sponsored study network. So for this test negative case control study, what they did was they identified individuals 18 plus years of age who presented with COVID-19-like illness at one of 9 healthcare systems within the Vision Network. And then their case definition was basically individuals with ICD codes associated with COVID-like illness in the emergency care, urgent care setting or hospital setting, and who had a positive molecular test for SARS-CoV-2. And then the non-cases were individuals who had a similar ICD discharge code in the same settings, but without that SARS-CoV-2 positive test. What's interesting here is if you just look at this top figure, and I apologize that these are very small. It's definitely a bit of an eye chart for me, so I apologize. So the nice thing about the test negative design is you can accrue a large number of cases. So they looked at over 250,000 potential cases to whittle down their study population to 21,000. But then they also were able to, because as we all know, the evolution of COVID-19 viral variation over time, SARS-CoV-2 evolves, they were also able to assess, in the context of this study, differences in severity of outcome by different SARS-CoV-2 viral variants. And then this bottom figure here just demonstrates, similar to the cohort study, that they were given the large sample size, they were able to conduct analyses by age, dose number, and time since vaccination. So, a lot of subgroup analyses that were very helpful in evaluating the effectiveness in an efficient fashion, right? That's the other advantage of the test negative design. So my second to last slide here is just to go over a non-exhaustive list of strengths and challenges of the cohort design and the test negative design. And I'll just caveat all this by saying that these biases, these strengths, these challenges are in some ways addressed and can be caused by the data source that you're choosing to assess effectiveness. So for example, the cohort design, its strengths are, minimal misclassification of exposure. The incidence can be calculated. You can do population-based sampling to allow for generalizability of disease burden. Some challenges are differences in health-seeking behavior need to be more tightly controlled. Larger sample sizes for these types of studies needed to be captured, need to be accrued to capture enough outcomes. You can have differential loss to follow-up and informative censoring. You need significant follow-up to estimate VE, and these can be resource intensive. The test negative design is an efficient study design that actually allows for rapid VE estimation, and it inherently can control in some ways for differences in health-seeking behavior. The challenges are, there could be selection bias based on testing decisions in a real world setting, incomplete information on test results, differences in health-seeking behavior based on disease severity. You're not able to really estimate incidence, and there's, generalizability issues, particularly of individuals without the clinical syndrome. And you have, sensitivity to prevalence of exposure and outcome for your VE estimates. So I'll just close by saying that vaccine effectiveness studies are important to fill key gaps from randomized clinical trial data with regard to subgroups and duration, particularly of a protection of vaccines. And as a result, regulatory authorities are increasingly interested in the generation of real-world data and real-world effectiveness data to support decision-making on licensure and indications and recommendations. Cohort studies, test-negative designs are two key designs that are utilized to evaluate VE, and each design has its strengths and challenges overall, and also based on data sources. So with that, I'll stop, and thank you for your time.
Speaker, but I made this really great sign up. So I'll try to count down for 20 minutes. Questions? 5, 2, 1.
Okay, thank you so much, Jen. Thank you, Morgan, for wonderful presentation. It is nice to see friends and colleagues, after like a year, which is really great. And I'm so privileged to present this topic with wonderful colleagues here. My name is Henok Taddese Ayele. I'm an epidemiologist by training and with background in infectious disease and pharmacoepidemiology. Today I will be presenting on test negative design for estimation of vaccine effectiveness. So I disclose that I'm full employee of Merck. Today I will try to touch 3 key issues related to test negative case control study design. And I'm so thankful that Morgan stays some stage for this. And I will touch on the issues of conventional cohort and case control studies and estimation of vaccine effectiveness. And also I'll try to describe few concepts behind test negative design. And I will highlight very 2 key assumptions of test negative case control study design. My objective is a little bit ambitious, but I'm hope that the participants will be able to describe the issues related to conventional cohort and case control study in estimating the vaccine effectiveness and explain the concept behind test negative design and identify at least 2 key assumptions. Okay, let's start from the challenges with the conventional cohort and case control studies. So we are epidemiologists, we know by training that observational studies by nature, they have their own limitation. I have one motivating example from the flu vaccine effectiveness where which required the estimation of vaccine effectiveness to monitor the impact of flu vaccine on the prevention of flu illnesses. This is because flu is caused by flu virus, and the virus by nature evolve every time which challenges us with new variant, and we have very good example with COVID as well. So for this reason, it required the frequent assessment of vaccine effectiveness of the existing vaccine against the flu caused by flu viruses and also new variant every time when it's apparent. Sometimes require this assessment every year. So these studies were actually aimed at to assess this association between flu vaccine and prevention of all-cause mortality in older adult. And these are the mix of case control and cohort studies. And you can see the odds ratio, hazard ratio of relative risk range from 0.2 to 0.8, signifying the flu vaccine can be effective from 20% to 80%. And if you see the median vaccine effectiveness, which is close to 50%. But this assumes that 50% of all-cause mortality in older adults can be prevented by flu. That means 50% of those all-cause mortality were attributable to flu. But as I said, there are surveillance ongoing everywhere, and which is looking at flu attributable mortality in older adult. And these are actually ongoing surveillance from 1960s to 2000, which has shown that flu attributable mortality in older adult was never been done higher than 10%. And if you see, I know it is small, but the median attributable mortality in older adult due to flu was 4%. So we saw in the previous slide 50% reduction, but now we are seeing 4% in the reality. So where from this discrepancy came from? There are different explanations for reasons behind, but one key issue is common, which is actually mentioned by Morgan, which is health-seeking behavior playing a major role in this bias. And colleagues, Lisa and Michael Jackson, who are the two colleagues with their friends, actually colleagues, try to explain this health-seeking behavior causing bias in flu vaccine estimation in older adult. As you can see from the result, these are the odds ratios of frailty markers associated with the likelihood of vaccination of older adult. Vis-a-vis the association between frailty markers and mortality. So as you can see, those frail older adults tend to vaccinate less, but tend to die more. So this is due to the bias of which is emanating from the health-seeking behavior. So what is the alternative? There are different ways to control this type of biases by design in conventional case control or cohort studies, but there is also an alternative, which is a test negative case control study design, which can partly address this type of issues. So what is test negative case control study design? It is, some people call them inverted cohorts, some call them proportional hazard ratios, proportional morbidity ratios, some call them same symptom, same diagnosis type of design, but these are semantics, and they are actually, we know test negative case control study design are part of case control design, nothing else. And how this design works, from the general population, you identify patients who seek care consistent with target disease, then you consent them, you enroll them, and test them for that target disease. If they test positive, they will be considered cases. If they test negative, they will be considered controls. And you will compare the prevalence of vaccination between case and control, and you identify the odds ratio and corresponding vaccine effectiveness. In identifying the cases, this identification of this case is similar to what we do in classical case control study design. But when it comes to the control, in classical case control study design, we identify control from the general population. Sometimes we have challenges to make them comparable to the cases, but this is not the issue with this design, and which is one of the main advantage. This test negative case control study design was first described by Matinen, who is a professor of epidemiology at McGill University in Montreal, who explained about this design in his book entitled Theoretical Epidemiology, which was published in 1985. The name test negative design was not mentioned, but the theoretical background was clearly described. If you want to understand more, then I highly encourage you to read the book. When it comes to the publication, the first documented publication which used test negative case control study design was the one published in 1980 in New England Journal of Medicine, which assessed the association between pneumococcal polysaccharide vaccine in preventing invasive pneumococcal disease. As you can see in their method section, this is quite popular 2x2 table where they define the cases as those vaccine type invasive pneumococcal disease, while the controls were non-vaccine type invasive pneumococcal disease. So they did one cross product of AD over BC, which is the odds ratio, and they found the estimated vaccine effectiveness. When we get back to the flu, flu required, frequent, assessment of vaccine effectiveness of the existing vaccine or the updated vaccine or new vaccine against the new variant. And it was challenging to do this with conventional case control or cohort study, but this new approach actually came into play in 2000 by a Canadian team. So this team actually identified flu-like illness, patients with flu-like illness. When they appeared to the sentinel physician, they tested them, they categorized them as cases when they were tested positive and categorized them to control when they tested negative, and they calculated the odds ratio and corresponding vaccine effectiveness. And now test negative case control study design is getting a lot of attention, and it has been used in flu vaccine effectiveness and also frequently in COVID vaccine effectiveness as well. And in 2022 alone, if you search test negative design term in PubMed, you would actually end up having more than 9,000 hits, which is still growing in 2023 as well. So how we would be able to estimate the desired vaccine effectiveness with less bias and efficiently from the test negative study design? I would actually go into the database of any type. It could be electronic medical record, administrative database, or population-based database. You would classify those participants with vaccination by health-seeking behavior and by infection with flu. But we need to make some simplifying assumption that care seeking is a binary, which is not the case in reality, but we assume that some people always seek care and other people would always do not seek care. So let's try to see the challenges. When we do this in the database, we always have a chance, to identify those people who comes to the hospital, which is actually in the red box, and these guys, and we will never identify those individuals with flu if they do not come to the healthcare provider. There is no way to capture them in the database, so we always miss them. So what would this, if we do a case control study and cohort study, what problem would we have then? Let's start with the cohort study. The challenge with cohort study is we start from the vaccinated individual and unvaccinated individual. From T0, we follow them until time T when they have an event, and we estimate the incidence of the flu in vaccinated and unvaccinated. We compare them. We have the relative risk and we have corresponding vaccine effectiveness. But the problem is the vaccine effectiveness estimates are confounded by health-seeking behavior, and also we will not identify those cases which are in cell D and J, which actually bias our estimate. What if we do the same, the case control study, we would have the same problem. We would have actually identified those individuals in cell A and G from the database, but we will not identify those individuals with flu in cell D and J because they are not seeking care, they are not captured in the database, and they would be misclassified as controls, which actually bias our vaccine effectiveness. And at the same time, health-seeking behavior would be a notorious confounder. So let's see somehow, what if somehow we are able to classify people into who seek care and who do not seek care. And we would actually estimate with relative risk with using the cohort study method, then we would have equal vaccine effectiveness in those who do seek care and who do not seek care. But we need to assume that health-seeking behavior is only a confounder. It doesn't modify the effect of the vaccine on the prevention of flu. If we hold this assumption, then we wouldn't have any problem. So we can ignore who do not seek care, and we can focus on those who seek care, who would be in which we'll be able to identify them from the database. So while we are doing so, vaccine effectiveness estimates are not confounded by health-seeking behavior, and vaccine effectiveness are not also biased by misclassifying those with flu, because on people on cell D and J are already automatically out of the numerator and the denominator of the incidence calculation. But the problem is we have a problem of distinguishing those people who are not infected in cell C and I, who do seek care, from those individuals not infected in cell F and L. They do not seek care in the database, it will be really tricky to distinguish them. So we're gonna have them lumped, somehow in N1 and in N3, which actually bias our incidence and corresponding vaccine effectiveness. So to actually come around, this problem, we can actually make another assumption, which is a valid assumption in some randomized clinical trial, which is if the vaccine doesn't work against or other acute respiratory infection beyond the flu disease prevention, then we would have other acute respiratory infection incidence should be equal between vaccinated and unvaccinated. If that is the case, the proportion of H over B would be N3 over N1. And if we somehow if we be able to replace H and B with N3 and N1 in the relative risk estimate, then we'd be able to calculate the odds ratio. How we do that? Look at this calculation, which is relative risk estimate, A over N1 and G over N3, which is the incidence of the disease between vaccinated and unvaccinated. So as I said, A plus B plus C over G plus H plus I is equal to B over H. So we can replace that. And finally, we will be able to say that the relative risk is A over B or over G over H, which would give you AH over GB, which is the calculation we get from conventional case control study designs, AH over GB, a cross product of case control studies. So this will automatically give us a test negative study design. This is what we call test negative case control study design. But to end up here, we need to make two key assumptions. The first one is health-seeking behavior is not an effect modifier. It doesn't actually affect the vaccine works, whether the patient seek care or do not seek care. This is the primary assumption. The second one is the incidence of other acute respiratory infection is similar between those vaccinated and unvaccinated, because the vaccine wouldn't work anyway in preventing other respiratory infection, then the incidence of those acute respiratory infection other than flu should be similar between the vaccinated and unvaccinated. These are the two key assumptions. But still we have like additional assumptions. For example, if the diagnostic test is not optimal, if the sensitivity and specificity of the test is low, and it would misclassify the case with the control, and we would have a problem, and it would bias our vaccine effectiveness estimate. The other assumption of routine, like classical observational studies like cohort and case control, like exchangeability, consistency, and others, should be also maintained. I think I'm over with my presentation, and thank you so much. I hope we have some time for questions.
Thank you so much for your presentation. My name is Joanne from Pfizer. So my question is for the test negative design. What type of data sources you'll be able to use for this type of design? Because the outcome is ascertained by test results. So do you typically need to do a primary data collection studies where you recruit patients and then test them, which can be resource and time intensive, or could this be done using secondary data sources where, but I guess the requirements that the data source needs to have the test results. That's a reliable test results. So I'm just want to get your insights about data sources to support this type of design. Thank you.
That is really a wonderful question. Let me go back to one of the example I provided here. This is the first test negative case control study. It has been conducted in Canada, and where they have this wonderful surveillance of flu. So everyone coming with flu-like illness, when they appear to the sentinel physician, they would automatically be tested, and the database would capture them. And it requires, this type of, routine assessment of those cases and testing. And if there are like some selection of testing more serious cases, for example, than less serious cases would have a problem. And otherwise, those type of administrative database or population database where there is clinical practice requiring a kind of routine or standard, testing of those individual would suffice the available, the potential of the data to be eligible for this type of studies.
So my question is as well related to the test negative design. Evan Anderson from Moderna. So what we're seeing is that there's a very strong link between COVID and influenza vaccination that is really, they seem to be very highly correlated. And so that can then complicate kind of test negative design, since the COVID vaccine may appear to actually decrease influenza burden as well. So has there been any kind of theoretical work done to help sort out that issue besides just disregarding flu status?
Indeed, that is a very good question as well. One of the key challenge of the test negative study design is the second assumption we are making, which is the vaccine wouldn't work against other similar infections, and that is a key assumption. And it works in many of flu studies being conducted, not only flu, but also in some pneumococcal vaccine effectiveness studies as well. There were some randomized clinical trials showing the incidence of other infections not affected by the vaccine are similar across the vaccinated and unvaccinated. But if this assumption is violated, and test negative study design wouldn't work, despite its all advantage and benefit would get, it's really tricky to identify valid unbiased estimate from those type of studies. And there are different colleagues actually try to show indirectly as click graph, which is DAG, to show how to minimize these biases with different techniques. And but still, it was a challenge, and everyone I saw in the literature recommend to at least keep this assumption hold as much as possible. Otherwise, it's going to be problematic, similar to other observational studies, including cohort and case control. Yeah.
Study has a different prior experience of the disease and prevented. That prior experience has an effect over the benefits of the vaccine. If you have the same initial experience that the difference between the vaccinated and the unvaccinated, you have initial to the past, the added benefit of initial vaccination goes to zero. If that population of people with prior measles experience some balance between the vaccinated and the unvaccinated, and you have not accounted for that, then you have a the most important danger.
Indeed.
There are others.
Indeed. Thank you. It's indeed.
Yes.
That's actually one of the issues I mentioned in one of my last slide. So it requires, the diagnostic test should be as optimal as possible. And if it is not, that you can play with around, with different, analysis, to do some sensitivity to increase the sample size, and whatever you do, you cannot avoid the bias. And you can, it's always, draw the vaccine effectiveness toward the null, which is underestimating the true effect of the vaccine if the cases are actually, misclassified and the controls are misclassified, which is one of the issue, but it requires some good diagnostic test close to optimal level, which is 100%. But in reality, we never ever had any test with 100% specificity and sensitivity.
Also, perform bias analysis.
Yeah. Yeah. Indeed.
Sometimes.
Yeah, we do that, and sometimes you can see, you can actually, estimate, how many, by how much the vaccine effectiveness could go down if you actually, misclassify this percent of like cases to control, for example. You can do that, but at the end of the day, it wouldn't actually gives you the right, the exact, vaccine effectiveness. That's the issue.
Hector, aren't you next? Here. I saw that fell.
Oh, I don't know. Jan, how can I get out of here? Sorry. So, my name is Hector Isurieta. I work for the Food and Drug Administration. So I am a regulator at heart. And I don't like observational studies. So disclaimer, I will try to challenge you with a few things. What's the main threat for observational studies? And there are many, but the one I love to work with and try to address is unmeasured confounding. I will provide you solutions to the problem of unmeasured confounding. First, I will start with the easy one. When you have a study that I will try to prove to you it's almost perfect despite all its limitations, and I hope you show that I'm wrong. That's a cohort study in which we compare the effectiveness of 5 different influenza vaccines using the elderly. The second one is a set of 2 studies on self-control case series, self-control risk interval specifically, that I proposed at the beginning of the COVID-19 pandemic to my collaborators in the Veterans Administration. They accepted the challenge, and we performed 2 of these studies. I'm not going to argue they are perfect. I'm going to argue that you can help me make them perfect, because if we succeed together in creating a design for the perfect self-control risk interval, then we will have what I would argue as the unbiased observational study. So let's see. Basically, unmeasured confounding, you know what it is. I will not waste time with it. I will present some potential solutions, as I said. A cohort study, comparative effectiveness between influenza vaccines. And in that study, we also use some negative controls falsification outcomes that I would present. And then I will want to spend the most time with what I would consider, I haven't seen anybody do it before we did it. What I mean is specifically use self-control risk interval to address vaccine effectiveness. So it's innovative in the use. Self-control risk interval is old, but I have seen nobody do it before we did it. So the first one is, I'm very proud to show you our comparative effectiveness of influenza vaccines in the 2019-20 season. just before the COVID hit. In fact, we had to stop the study early when we saw that COVID would interfere too much with our work. This is one of our patients, members of beneficiaries of Medicare during August to February 29, 2020, over 12 million vaccinated fee-for-service beneficiaries. We compare these 5 influenza vaccines. And the basic assumption is equipoise, meaning whoever vaccinated these people was indifferent to giving them this vaccine, standard dose, quadrivalent, or egg-based high dose, or adjuvant dose, or cell culture, or recombinant. If that assumption is wrong, then disregard the result of this study. Now, we use inverse probability of treatment weighting, which my collaborators at Acumen love to use. I have only admiration for them, but I will prove to you that this was totally unnecessary and a waste of human resources. And then for the outcomes, because in Medicare studies, we have the claim and the outcome is completely, bogus almost. So we restricted the analysis to high influenza circulation period. And in the main analysis, we use hospital encounters. I will ask you to disregard that and focus on inpatient hospitalizations. Its specificity is higher. So if you are with me, here is what we did, and I will want you to challenge me on this. I proposed to my group to analyze a number of potential health-seeking behavior negative endpoints. We call them falsification outcomes. This list of outcomes was generated by expert judgment, in fact, my judgment that the group accepted. And if you find ways to suggest that they are not good, please bring them to me. In fact, I stole one from a friend, Yinong Yongchu. This one, but not in the original list that we published in Pharmacoepidemiology and drug safety. But there is something really interesting here. When we try to check for all these, let's call them falsification outcomes or negative endpoints, the standardized mean differences, which is, Austin created this and I love it. It's supposed to be less than 0.1 traditionally, right? They are very low before we implemented inverse probability of treatment weighting. And then, yes, they improved a little bit afterwards, but they were not bad before inverse probability of treatment weighting. So I challenge you to tell me why. Anybody? Going 1, 2, 3. Well, because the study was perfect. That's it. The populations were really comparable. This proved my assumption of equipoise. That's what I mean. If you get to a comparative effectiveness study and you can show this table, you don't need a statistician. You don't even need to analyze the data. You just look at the numbers. Okay. What I mean is, I'm very proud of this study, but we were just lucky in the year because we did the studies in 2 years before, 3 years before, 4 years before, and we never get to that kind of data in the perfect equipoise environment. Anyway, this study and another one that we published in Lancet Infectious Diseases were used by CDC to propose preferential influenza recommendations. So this is the easy way, right? But let's go to the more complicated way. We performed 2 self-control risk intervals with the colleagues from the VA. One of my colleagues, the main investigator, Caroline Corvez, will present in the plenary this second study in detail. But let me try to explain what we did and why I think this can hopefully take us to the unbiased study. In self-control, as you know, the time-fixed confounders are implicitly accounted for. In this one, what we did is we tried to use as control period. This is a vaccination date. The control period was days 4 to 6 post-vaccination, meaning people who had events, in this case, COVID, in days
4 to 6 post-vaccination were not yet protected by the vaccine. This in this study, the analysis was for Delta and Omicron BA1 period. The incubation period for Delta is around 4 days, 4.4 days, basically, and 3 for BA1. Therefore, if the person has the case in this window, it likely happened after vaccination or on the day of vaccination. The infection likely happened there. So it should be okay. There is a power problem here. And then for the comparison window, we use days 14 to 16 post-vaccination. So -2, 3 days or 3 or 4 days, you still have a period in which the vaccine should have been effective, but not necessarily at its peak. So that's one of the problems we are going to try to address. Period during which the vaccine is effective, booster period. Period in which the vaccine is not effective, control period. Time fixed confounder implicitly accounted for. Now, we also did use a negative control exposure. Instead of using COVID vaccination, we use influenza vaccination. If you get vaccinated for influenza and you get the disease, COVID, which influenza does not prevent, influenza vaccine does not prevent COVID, that's informing the group, then we are supposed not to find any difference. Now, here in this exercise, we did forget to, not forget, we just couldn't account for timing of influenza vaccination with respect to the COVID epidemic curves. So although this study did not find an association, this may be a power issue. It may be that by not accounting for any correlations between the timing of influenza vaccination and the pandemic,
I'm just going to change the view while you keep talking.
thank you.
Because
Then we may have accepted some degree of bias. So take this into account if you do it, correct our mistakes. The results were very similar to other studies, and among other studies, the one we did with Yinon Changshu using test negative case control. But most studies found numbers of vaccine effectiveness similar to what we found for Delta and for BA1. Now we are invading the BA4-5 territory, right? There have been some studies, immunogenicity studies, that show very little immunogenicity. And well, we were curious. We used a very similar design. We changed a couple of days a little bit, and we analyzed the period of prevalence of BA4-5. Same design. I will not waste your time with it. And our results were, to my surprise, lower. In fact, in our study, the results of vaccine effectiveness were not significant. This may be a power issue, but the estimates were low, much lower than for BA1. So there are a number of explanations for that. One, effectiveness of the bivalent vaccine against BA4-5 was not great, which is what some of the studies I'm citing here say. Or we made a number of mistakes, and you will help me clarify where we land. Now, I will not be conclusive. I will not tell you what's the truth because I really don't know. We compared this with a test negative study we performed at the same time, which gave higher estimates. And as I was trying to demonstrate, test negative studies are not unbiased either. We can discuss that later. You know, there is an issue with who goes to take care in a timely manner. Is that person more likely to be vaccinated or not, etc., prior infections and all that. Well, I will try to get into the advantages and disadvantages of the self-control. By using self-control, we implicitly adjust for time-fixed confounders, as I said, but we also implicitly adjust for things that are very difficult to take into account in almost any observational study. Prior COVID history of vaccination. So prior COVID history and history of prior vaccination. Sometimes you don't even know who was vaccinated in your database. Because the incubation period was shorter, 2.6 days, then we have a higher likelihood, a better likelihood of falling in the right window. Because if you get the case on day 4, but you were infected prior to vaccination, then the healthy vaccinee effect will affect your results much more same for one window being confounded with the other window, and so on. I can elaborate in the question section if you want. There are other advantages. Because we use short intervals between windows, we were lazy and we did not adjust for time varying confounders. We said, what the heck? We use very narrow windows. We escape the thing. But if you want to do it right, I would say create an offset term. And that offset term could be the proportion of, the cumulative rate of, let's say, COVID in this case, in the average booster period divided by the cumulative rate of COVID in the average control window. And that factor, that offset term, is added to your regression. And then you are just adjusting for this time varying confounding. Same for other time varying confounders. It's a simple way to do it. I mean, I'm incapable of doing it. I'm not a statistician. I'm sorry. Don't ask me statistical questions, please. And then limitations. Well, the testing, I think it was Morgan who said home testing. In our second self-control study, home testing was widespread. I had COVID and I did not go to the doctor. I just tested myself at home. My wife, who was photographed with me in that confession, she also had COVID. She didn't go to the doctor. Shame on us. But that happens to a lot of people, So that's a limitation. And how can you address that? There are a number of things, but something we are planning to do, if I can convince our colleagues in the VA to go back to this data, is look at real onset date from medical record review. There are other limitations. We use days 14, 16, 14, 17. Next time, I would use an offset term if I can get away with it and convince my colleagues to do it, and then use larger windows. We could use days 14 to 40 or 45. So we are still analyzing short-term effectiveness. But if we wanted to study waning of effectiveness, we could use multiple windows. If somebody is interested, I have not yet done it, but we could, do a sliding set of windows that give you different estimates of effectiveness for different periods. Nobody has done it yet, and it could be beautiful. Then the control window, we use very short control window. The problem with that very short control window is that that's very difficult to replace, because if we use pre-vaccination control windows, you get into a number of health-seeking behavior, the healthy vaccine effect and etc. If you are going to use a pre-vaccination control window, I suggest use days -16 to minus whatever. Don't get into the 15 days prior to vaccination, but still not very good. The other thing is just increase the power. Instead of having just 9 million people, have 20 or 50 million people. If you can get away with it, then you will have the best study. But those are potential solutions. So in conclusion, observational studies, unmeasured confounder is what I worry the most first myself, because it's very difficult to resolve. Comparing effectiveness of vaccines with the same indication, if there is a good assumption of equipoise. If you do that this year, after the CDC has recommended that 3 of those influenza vaccines are the good ones, right? Or the better ones, then you are cooked. But you can still compare between the 3, right? So the CDC has not spoiled the whole fun. Then I didn't insist too much on that because Jen didn't give me time. I have 2 minutes. She's looking at me. Negative control exposure, negative control outcomes, double negative controls. I love them. As I said, I'm not a statistician, but please teach me and use them. I think they are good approaches. The ones I suggested for health-seeking behavior, criticize them. I love to. And then self-control methods. I already discussed the good, the bad, and the evil. So I'd like to thank all my collaborators, and from FDA, from the Veterans Administration that are presenting one of these studies tomorrow or the day after tomorrow, CDC, Jeffrey Kellman from Medicare, all my colleagues from Acumen LLC, Nick Andrews, Bruce Fireman, who criticized some of my efforts a number of times. So they have me address the problem. And thanks, everybody. If you have any suggestions, I will be here all week. Thank you. Yeah, I mean, it's like racing, racing in a very powerful car, right? I would argue that if you want to play safe, use comparative effectiveness studies. If you want to risk comparing the vaccinated with the unvaccinated, first, randomize, because it's very difficult to find a very well comparable unvaccinated group. If you are forced to work with the unvaccinated, one of the approaches is the one you have presented that I would favor in general, which is test negative. There are others. There are still limitations, but it's very difficult to compare in a cohort analysis vaccinated with the unvaccinated. For self-control, it doesn't really matter because everybody is vaccinated. The comparison was the prior vaccination, which could be 0. So for self-control, there is no problem. I can elaborate or if you need some. Any other question? Yeah, in general, I like pandemics and epidemics because in such a situation, everybody is scared and runs when they are told to run. So if you study a vaccine in the midst of an epidemic or a pandemic, you go to get vaccinated when the vaccine comes to you, or you don't if you are a non-sayer. So I was not very worried of that problem in the midst of a pandemic. But if we are talking about an influenza vaccination self-control study and choosing a control window, I would be more careful. I would try to analyze other similar periods and see, do a test in a prior season and check for what happens days -20, -30, days +4, +6, etc., and see where the real unprotected people are. We can work that out, but I haven't done it. But I love for you to try or for others to try.
Sample size. I was just curious if you thought about trying other vaccines, like pneumococcal population as a negative control.
Yeah, I mean, sometimes in life you have friends and you have non-friends. Pneumococcal vaccination is not my friend. I have failed in one pneumococcal vaccination study. It's a different population. It's not so representative. Influenza, everybody loves influenza vaccines. I have no idea why, but everybody does. So I feel safer with influenza. But we did not account for a number of things when we used the influenza window. I would use some adjustments, an off term, things like that. But yeah, it was on purpose, my choice. The choice I suggested to my collaborators.
All right, well, we're going to transition back to safety, but first, I think everybody should get up, stretch. We're going to be here for a few hours. So, okay, we can go back to our poll while we're taking a minute for a break, and we see, kind of as expected, most people are from North America, a couple from Europe, and it looks like, 1 or 2 from Asia. Thank you for among those who answered the poll. I'm going to try and open a poll where you can submit questions that we can consider for the panelists if you're one of those people that doesn't want to speak up in front of everyone. because we have different kinds of learners here. So I'll leave this up just for a minute for you to write down the poll number or scan the code, and then we'll have Bob Chen up in about 3 minutes. And I want to just take this moment to thank all of our many presenters who are here. I think if you look at the rosters for the agendas for the other courses, you won't see 9 speakers. And that's because we have a lot of volunteerism among the big vaccine dorks here at ICB. So thank you to everyone who's here presenting today and who came to take this course. So we'll reconvene at 3:10 with Bob's intro to vaccine safety.
Thank you, Jen. So I'm going to shift gears a little bit, not only in terms of topic, but also a bit in the context. This has been more of a health policy talk rather than kind of hardcore pharmacoepi. And in part, vaccines are a bit, let's say, more public health than kind of traditional drugs. And so it's useful to try to highlight a little bit of some of the differences here. So I'm Bob Chen. I'm the scientific director for the Bryden Collaboration. And the take-home messages that I want to share is that obviously immunizations have been greatly successful in the past. They're needed in the future. We've had several traumatic vaccine safety challenges worldwide in recent years, and COVID-19 highlighted many of them again, and that this is due in part to the fact that we're in a unique moment in the history of our species, Homo sapiens, that I'll try to explain why that is, and that as with all species, we need to adapt to this new paradigm and this kind of a life cycle approach that I propose, and this requires involvement of all societal stakeholders, not just us. This is just a reminder of the fact that many of the diseases that we immunize against, we don't hardly ever see anymore, and yet they're very, still in their natural setting, awful diseases, and this is true of smallpox, etc. And we want to continue to prevent them. So the number of vaccine-preventable diseases are increasing with our genomic and biotech revolution that we're able to sequence and then ultimately, hopefully, make a vaccine. And with each VPD, kind of the morbidity and mortality of that wild disease obviously results in the priority that we accord to the development of that vaccine. And the epidemiology of that disease impacts on target populations and kind of the different target groups for the immunization program. I've listed some resources on VPDs in general. Now, in terms of, you've just heard about kind of efficacy and effectiveness, the nice thing about it is that it's easy to measure, relatively speaking. You look at the reduction in disease in vaccinated compared to unvaccinated, and just a simple mathematical calculation. You do need to figure out the incidence of the target disease, and usually there's highly specific clinical or laboratory diagnosis available. And with sample size of a few hundred or 1,000, usually you get a reasonable estimate. Safety, on the other hand, usually cannot be measured directly. We have to infer it indirectly by relative absence of multiple AEFIs, or adverse events following immunizations, and sometimes you only know ahead of time which ones may be an AEFI. Frequently you don't. You have to be open to something totally new, be it myocarditis, be it TTS, etc. And some of these are clinical syndromes that we don't know anything about the pathogenesis. So it's a much more difficult assessment compared to efficacy or effectiveness. And this is just simply, kind of going back in probably the professional lifetime of most people in the room. There has been kind of one controversy or another in one country or another. And so why is that? Is this just simply that Shakespeare was knew that among humans you have different individuals, each with their own story to tell, and that are the conspiracy folks out there correct that we're all just out there to make a profit and we're just hiding the truth. I want to kind of present an alternative paradigm. The first part of it is that a higher standard of safety is expected of vaccines for multiple reasons. Obviously, the first do no harm in principle is important, as in all of medicine, but that in terms of public health, because our the vaccinees are generally healthy at the time that they receive the vaccine compared to people who receive drugs who are already ill. That changes the equation in terms of acceptance of the risk. And then also vaccinations, because they do frequently have a herd or community impact, they're universally recommended or mandated. So that translates to a lower risk tolerance and a need to search for more rare reactions for vaccines. So frequently events as rare as 1 in 100,000 or 1 in a million are enough to change policy when it is given to millions, or in terms of COVID, billions of people, whereas in drugs, if you are sick with cancer, you're willing to tolerate 100% serious reactions. And obviously, any study of rare events are going to be more costly, more difficult, and less likely to be definitive. Now, if you take a look at the actual statistics, the data in white on the bottom is something that most high-income countries at least have reasonably good data in terms of the impact of the immunization against each one of these VPDs from the pre-vaccine era to a recent year. And here I've shown kind of most recent data from that's available for US is actually from 2020 for kind of the final compiled data, and obviously close to 100% reduction because these are very effective vaccines. Now, the one line in yellow that unfortunately the programs don't publish is that in terms of vaccine adverse events, on the other hand, we've gone from 0 cases in the pre-vaccine era to year 2020, about 6,000 reports after these same vaccines against diphtheria, et cetera, et cetera. The total, and these are reports to the vaccine adverse event reporting system, the passive system, which actually has a total reports for about 38,000, but I restricted them to have a apple and apple comparison. And one of the challenges in this field is that most of us working in public health instinctively look at this issue in the horizontal perspective in terms of the incredible power and value of immunization. But we forget that the average non-public health person walking on the street sees and experiences this in the vertical perspective. That is that they're just as likely to experience an adverse event as they are to see a wild disease from these. And so there's kind of a built-in miscommunication that is inherent in this field, which makes it difficult for us to actually communicate with the public because we just come at it from a totally different perspective. Now, this previous slide could be generalized into this kind of complex slide showing the evolution of the immunization program, where on the x-axis you have maturity of the immunization program, and on the y-axis you have incidence of 3 things: wild disease in blue, the vaccine coverage in red dashed line, and then adverse events in yellow. And there are 5 phases here. So in phase 1, before you have a vaccine, so currently we don't have a vaccine against HIV, and until kind of recently, we didn't have a vaccine against COVID. All you have is a high rate of disease. And then if you have a safe and effective vaccine that is used in increasing coverage, then obviously the wild disease comes down. But you also have an increasing number of adverse events, both true reactions to the vaccine and coincidental adverse events that are blamed on it. At sustained high coverages, the 2 lines approximate each other, as you saw in the US data that I showed on the previous slide. that then makes it very easy for a media scare to occur, and then for vaccine coverage to drop. And this has occurred, with diseases like pertussis and measles vaccine after the autism scares, etc. And then you have a return of outbreaks. Now, if you're able to kind of recover your coverage, and that did fortuitously occur once the safer acellular pertussis vaccine was introduced, and despite Wakefield, ultimately the measles coverage in UK came back up, and so the disease came back down. Now, with a few diseases, with smallpox, for example, they were able to actually eradicate the wild disease. At that point, then they were able to stop the vaccination and then eradicate the adverse event. And so that, in general, is the ideal framework. But if you rethink about that, unfortunately, in the era of bioterrorism, we actually want to rethink that. So if you hearken back to Columbus and all the other great explorers in the 1600s, one of the things that happened was that different native populations around the world were decimated by the introduction of measles and smallpox. And so at that time, the smallpox vaccine, when it was eradicated globally in the late 1970s or early 80s or so, the vaccine was so unsafe, they said, well, it's better to just stop using it completely. And so what's happened now is that we have a growing cohort of people who are susceptible to smallpox that makes us vulnerable for a future bioterrorist attack. And so similarly, if same thing happened if we kind of eliminate measles and stop immunizing against measles, again, we would be similar to the 1600s. So the alternative then is that number one, very few diseases are actually eradicable in the first place. So that means the vaccines have to be used continually anyways. And then even if they are eradicated, and even for smallpox, we may want to rethink it. It's better to actually immunize the population with a safer vaccine. So we are then back into this phase 3, where we have high coverage with relatively low disease and relatively prominent adverse events. It's better for us to research to figure out which of these adverse events are truly due to vaccination, and make a safer vaccine, and then allow us to be able to vaccinate forever rather than stopping. So, being able to establish a causal link between adverse event vaccine is very important. We're in a few situations, we have able to do a unique lab findings. So somebody receives a mumps vaccine, develops aseptic meningitis, you do a spinal tap, you grow out the mumps virus, you do genetic sequencing, and show it's a vaccine strain, not the wild strain. That's a laboratory confirmation. If you have a unique or relatively unique clinical syndrome, so 18 to 25-year-olds walking on the streets don't frequently have myocarditis, but if they start to develop myocarditis about a week or two after vaccination, that's probably a true vaccine reaction. But unfortunately, of those 38,000 reports to adverse event to the U.S. VAERS system, only a handful have unique lab or clinical syndrome. So you have to rely on either an epi study or large clinical study where you do your rate calculation to see if there's a higher rate in the vaccinated. And obviously you need to complete a 2x2 table of vaccinated yes, no, and adverse event yes, no, and to do that calculation and obviously do that in an unbiased manner. The problem with the traditional passive surveillance system is that's really data only from the cell A of the 2x2 table, people who've been vaccinated with the illness or syndrome, and even then it's underreported and biased cell A. So you have less than 1/4 of the information scientifically needed to do your rate calculation. And so less than 1/4 of a hand clapping is obviously not very loud. So lessons from such a 2x2 table is that any time that you have a mass vaccination exposure, as we did in COVID, you're going to have many vaccine adverse events, because anybody who comes down with a medical problem will likely to have had a recent vaccine exposure. And people are full of hypothesis generation, and you want to be open to new hypotheses, because some of these could be real. And historically, kind of trying to do ad hoc outbreak investigations are quite challenging. They're kind of politically sensitive, and so if you have different kind of a large link database record linkage set up ahead of time, then that allows you to explore these issues more quietly. And the classic record linkage studies, I think most of you are in here for, because you're intermediate and advanced class, knows that kind of link the vaccination exposure records to the health outcomes, and then control for potential confounding with the unique identifiers. And the vaccine safety data link was kind of the first of these in the US. Now, the other part of it is that it turns out that in order to maintain public confidence, this turns out to be a very complex multi-step piece process in which there are different infrastructure that are needed. So on the far left, we have the passive surveillance system with the yellow card, VAERS, etc., for hypothesis generation. And one would kind of say the cohort event monitoring type of active surveillance that was very popular during COVID-19 is also in the hypothesis generation box. Then on the far right, with the large link databases, you use them for both background rates and for hypothesis testing. But in between, there are kind of a couple other important activities. We need kind of clinical assessment for a new syndrome to sort out, what is, what is this new problem, be it the TTS, for example, these people developing clots all of a sudden and dying on you. What is this new clinical entity? And you kind of need a group of people who specialize in that. And then you need to develop a case definition to figure out how exactly are you going to code and report these out to make sure the data is comparable. And then on the bottom, you need to have a way to communicate this information to the public. And then on the right, a new technology development to develop safer vaccines. And then this life cycle obviously begin frequently with the initial case report, and then with standardized assessment, you want to get to a case series. And then if you think it's biologically plausible, then you find the resources to do a controlled study. And in these days, again, if we have these databases in place, it makes it easier to do that. And then once you have the results, you want to communicate that to both the society and the individual for their kind of risk-benefit policy making. And then if you understand the pathophysiology, has impact on treatment, compensation, development of safer vaccines. And then if you're able to identify the risk factors, you could do appropriate contraindication and screening. So I'm going to shift gears a little bit. So kind of historically, the top part of it is really kind of what pharmacovigilance and pharmacoepidemiology is focused on. But now we have a lot of very active anti-vaccine people, or people who are classified as anti-vaccine, but in fact, frequently they're not. And I want to argue that we want to take a different perspective on that population. So in general, many of these adverse events are rare, and it is difficult for each clinician to treat them because in general, they see so few of them that it's impossible for them to move the science forward. And so the issue that occurred to me back about 20 years ago is that we don't expect the average primary care physician to advance the science of leukemia on their own. They occur too rarely for the average primary care doctor to advance that science. And so what we did was that we organized regional centers for hematology oncology, where enough rare cases of leukemia could be referred for clinical trials to be organized, so that over my 35 medical career, it went from a initially universally fatal disease to now universally treatable disease. And so we need to adopt the similar model in the vaccine domain, that despite 200 plus years of Jenner introducing vaccination, we never created a similar framework to study these rare adverse events. And so we need to develop academic centers of excellence with vaccine safety clinicians, with the ability for clinical subspecialty for referrals, because it's hard to know which part of the organ system they will occur, and we need to have top-notch laboratory research capabilities. And part of this is that at the end of the day, the response to immunization is probably a bell-shaped curve. Some people under-respond, some people over-respond. The immunization trials and programs and recommendations are targeted in general for the people in the middle of that. And those people who under-respond, it's very simple. Just give them more doses of the vaccine. The problem is people who over-respond. Historically, we didn't have a good way to deal with that, and they tend to get swept under the carpet. And that then starts to create a problem when you start to sweep a biological phenomenon under the carpet. And so if we could create standardized assessment and management of persons with either known reactions or suspected new syndromes, should they get the next dose or not? And we want to increase the scientific understanding of these outliers, and then maximize utility of our kind of data systems. And historically, if someone goes to the doctor after their first dose and had some kind of problem and raises the question, doctor, should I get my next dose because I had this bad experience with my first dose? It's a totally rational question, but somehow, sometimes they could be classified as an anti-vaccine person, when in fact it is just a totally rational question. So by creating such systems, we could kind of convert from kind of a lose situation to hopefully a win-win system. And we've now created a global, a new international network of special immunization services on the bottom that I mentioned to try to solve this problem. Okay, I'm almost out of time, so I'm just going to get the highlights. So the past success is no guarantee of future success. This is the first time in Homo sapiens where previously we acquired our immunity through wild disease with a high price paid in morbidity and mortality. We want to shift to vaccine-induced immunity with a lower price paid in morbidity and mortality. But this is the first time in Homo sapiens that we're doing this, and so it remains to be seen how do we create such a sustainable infrastructure. And we need a credible, effective, and sustainable immunization safety system with appropriate resources, infrastructure, et cetera. And in addition to control and eliminate vaccine-preventable diseases, we want to eliminate vaccine-induced disease as well. And let's make that a goal as well as the traditional immunization program. Okay, so I think I'm out of time. And if there is some leftover time, I have some ideas on how the global safety infrastructure worked and what we can do to improve it going forward. So let me just stop and see if there are any questions.
how our civilian system would find it a rarity, the rare program of members in the something like that, very rare, but not in our predefined diseases. Also, we could do like a population profile to do top 100 diagnosis among this vaccine population. Still, we couldn't find that disease in our top 100 lists. I was wondering if that could be.
Yeah. So your only solution is really a good passive surveillance system. Yeah, the various type systems are amazingly powerful because they're very timely. If you take a look at the be it anaphylaxis, be it TTS, be it myocarditis, kind of within, I would say, a month of these reports, the system was able to detect them in the countries that are functional. So I think you just have to be open-minded and make sure that the system is working routinely, be it for drugs, be it for vaccines, et cetera. Yeah, well, like anything in public health, right? You have to prioritize, okay, and so the events like TTS and myocarditis were worrisome enough not only to the patients but to the clinicians to report, et cetera. So it's in general, if it's just another unusual type of rash, for example, that's not really worthy of if you have other more serious outcomes. So again, there's no no simple rule, but obviously the regulators historically have come up with some criteria for what they consider serious, and those are probably reasonable starting points.
You have limited resources that training the quality of data for people. I would argue, and I like that I rather focus on serious events, maybe hospitalized events, emergency events that I could target more and get a better understanding as opposed to common events that are not serious, that do not challenge the vaccine program, but like a large majority of researchers and vaccines as well. That's really.
Yeah, well, again, once you create a passive system, right, just by inherently in terms of human behavior, there's going to be a bias towards the more serious events coming in. It's built into it. So again, it's not a 100% system. Passive is voluntary, and people are busy people. They'll prioritize things that are more serious. But anyways, I think some of this is somewhat academic in the era that hopefully we may make it to more electronic reporting, and everybody walking around with some kind of cell phone. There's ability to get more data than we could possibly imagine, and hopefully we can solve some of these issues. Okay, I think my time is up. Let's see, get out of
Already here.
here. Okay, and I'll let you.
Thank you. Slide.
Hi, good afternoon, everyone. My name is Joanne Wood. I'm a Harvard-trained epidemiologist. I'm currently working at Pfizer, leading post-approval safety studies and supporting products such as RSV vaccines and tofacitinib. I'm so delighted here to be today to present a short course that's entitled An Overview of the Vaccine Safety from Pre-Approval through Post-Approval Surveillance. Here's my disclosure. So I'm an employee and stockholder of Pfizer. And for disclaimer, all the opinions expressed today are solely my own and do not express the views of opinions of Pfizer. My presentation is divided into 3 parts. The first, I'll provide an overview of the vaccine development approval process in the US. And second, you may already heard from the news, the newly approved RSV vaccines for the older adults and also very recently for maternal indications. This is a historical moment as this is first time we ever have RSV vaccines. So I will talk about the RSV vaccines development program for specific Pfizer's vaccine, Abrysville, for the older adults in the context of the vaccine development approval in the US. And this last part of my talk will be specifically focused on those post-approval safety studies that are requested by the FDAs for the RSV vaccines for older adults. And I will talk about why they were requested by the regulators and how they were designed and how do we plan for those post-approval safety studies. There's several key milestones in the vaccine life cycle. First, if a sponsor wishes to begin a clinical trials with a vaccine, the first must submit an investigational new drug application to the FDA. And this is also called the IND. The IND will describe the vaccine, its method of manufactures, and its ability to elicit immunogenicity and its basic safety profile. And also the sponsor's plan to test the vaccines in human beings. And FDA will review this IND, and after FDA approves, this vaccines needs to go through 3 phases of clinical trials. I think you may all aware of those phase 1, 2, and 3, and the sample size increases through those trials and also the length of time. And the phase 3 trial usually is the pivotal trial to determine the vaccine's effectiveness and also safeties. And if the vaccine demonstrate adequate or favorable benefit risk profile, the sponsor will submit biologics license application, also called a BLA, to the FDA. The FDA will review the data, assess the risk benefit profile, and determine whether this vaccine should be approved. And during this process, FDA will also host a public hearing called advisory committee, or you may heard of this term, VRBPACs, for which I was part of as the responder for FDA for post-approval safety plans. And after FDA approves the vaccines, there's a committee called the ACIP, which stands for Advisory Committee for Immunization Practices. So they make the recommendations for how the vaccine should be used in the US. It could be a risk-based recommendations, could be age-based recommendations, and you will get to hear the ACIP's recommendations for the RSV vaccines for older adults specifically, and later on in the talk. And the phase 4 begins, which is the phase to assess the it's a post-approval surveillance phase to research and monitor the vaccine safety as well as effectiveness. But the primary focus of, I would say, for the post-approval phase is to understand the safety. So now I have a similar, questions is, why do we need post-approval safety studies? Isn't RCT enough? So I think Morgan may have touched base for the post-approval effectiveness studies, why they're needed. So my question for you, as you have heard our talk so far, is why post-approval safety studies are needed. Any ideas? You just want to shout it out, and then I can just see if you hit all of the answer key that I have pre-made. Exactly, population. And then I have to click the box to see I have the answer, but I don't have the answer key. I don't. Okay, here we go. So it's the population. So this is the right one. Okay, here we go. So it's a special population because some population they're like excluded from the trials, right? They're less represented. So special populations. Let's give it another attempt and then see if we can hit another answer. Then we're going to move on to the next slide. Yes. Exactly. So I think this is the right box for the rare events. Let's see. Yeah, it is. For rare events, those are not, RCT is not powered to detect rare events. And on the similar note is the latent events, because RCT has limited follow-up time. So latent events need post-approval safety studies to further evaluate. And I have here is missing information. This is on the similar thing as a special population where some population were just excluded from the trial, such as pregnant individuals and pediatrics, or patients with, like for the RSV trials, populations with immunocompromised conditions, they're excluded from the trial. So they represent the missing informations. And finally, you may have other safety concerns that arise during the post-approval phase that were not found through the trials. So post-approval studies are really pivotal to understand the safety profile of the vaccines once it's being used in the real world setting. Here are just some example of the post-approval vaccine safety surveillance. CDC and FDA, they routinely monitor the safety for approximately 15 vaccines, as I just counted from the website, through its passive and active surveillance systems, such as, but not limited to, the VAERS, the VSafe, and the VSD. And also, as you know, during the pandemic, such as the H1N1 influenza pandemic in 2009, and also more recently, the COVID pandemics, some of those severe and rare safety events, such as Guillain-Barré syndrome or GBS or myocarditis, those were rapidly detected through the post-approval safety studies. Okay, so now you're aware of the general vaccine development and approval process. We will contextualize that with the recently approved RSV vaccines for older adults. Just a little bit of background for the RSV disease itself and also for the vaccines, for those of you who may have not heard of. So the RSV is the virus called respiratory syncytial virus, and it's an important cause of severe respiratory illness in older adults, infants, and children under 5 years old. There's a very high burden in the US adults older than 65 years old. It is reflected by the high number of annual hospitalizations and also death. The abrysivils, it's a bivalent stabilized RSV prefusion F vaccines. I know it's a little bit lot of jargons and technical terms, but it is not an mRNA-based vaccines. So maybe that's the only take-home message. It's a vaccine made of proteins. So as I said, this has been approved for older adults, and I think there's another vaccines, but GSK is also approved for older adults. And for the maternal, at the time when I was preparing this presentation, FDA hasn't approved this for maternal immunization, but now just I think on 21st is now approved. So it's the only vaccine right now indicated for maternal immunizations is to protect the infants from birth through 6 months of age by actively immunizing the pregnant individuals. I won't go into the maternal indications. The talk today will be more focused on the older adults indications. In terms of abrysivill's clinical development program, it closely follows the vaccine roadmap that we have just seen. And I don't include the pre-IND phase. And here, what you just shown are the phase 1, 2, 3s. The phase 1, 2, from the phase 1, 2 trials, there's important milestone is to be able to select a formula. Oopsie. And then the phase 3 studies include a couple of studies, but the pivotal trial is the RENOR clinical trial, which is randomized, double-blinded, placebo-controlled trials that has recruited 35,000 participants at the time of licensure. And it was across 7 countries, including the US. So it's a very large trials. For the abrisovir, in terms of the efficacy, it's highly efficacious towards the RS infections caused by the RSV, and particularly for those the RSV infection with more worse symptoms at 86% efficacy. For its safety, it's the rate of adverse events profile are comparable between the vaccinated and the placebo groups. There's some numerical imbalance observed for events as Guillain-Barré syndrome, GBS, and atrial fibrillations, AFib. The number of events are very low to warrant any formal statistical comparisons. And due to the safety concerns, FDA has requested Pfizer to conduct 2 post-approval safety studies to further evaluate the risk of GBS and AFib in a real-world setting after licensures. Okay, I'll talk about more about those studies in the last part of my presentation, but I promise you I will let you know the ACIP's recommendations for the RSV vaccines for the older adults. So the specific recommendation is adults 60 years of age and older may receive a single dose of RSV vaccines using shared clinical decision-making. So this is not the strongest recommendation that ACIP can make. And there's some consideration behind those recommendations that includes those opportunities that needs to be further describe the benefit risk profile of the RSV vaccines. That includes what's the durability of the protections and whether the booster is needed. And also what about effectiveness in those frail or immunocompromised older adults who are excluded from the trials? And the safety, how about the safety and efficacy of co-administration with other vaccines, such as flu vaccines, COVID, and also the safety topics that we just see from the trials. Okay, so now we transition to the last part of my presentation that are specific focus on those 2 post-approval safety studies that are requested by the FDA. I was specifically talking about how we conduct the feasibility assessment for the fit for purpose data source for the post-approval safety studies, and also how we decide those milestone dates. For the feasibility assessment of fit for purpose real world data, there's a lot of consideration going to that. And this topic alone can be a lecture on its own. So today I will only be able to give you a flavor of it. And so those important elements for consideration, including what is for your specific outcome interest, what would be the background rate? Because based on the background rate, that determines for the data source, what would be the sample size needed for your sample size, for your data source of older adults. And also, would your data give you enough generalizability to the general US adults or only to some specific US adults? And also, were you able to ascertain the vaccine exposure in your data source, and how you are able to ascertain the outcome interest, such as GBS? And are you able to have access to the charts to confirm the outcome interest in your real world data sources? Is your real world data source a longitudinal data, which means are you able to ascertain the outcome are you able to follow the patients like after vaccination to ascertain the outcomes? And also, is your data timely, which means what's your data lag? And data lag refers to when the time between a patient's had a healthcare encounter and the person's healthcare data appears in the data source. And also, given those are regulatory mandated studies, has those data sources been used in prior post-approval safety studies? Because if it's a new data source, we have to demonstrate to the FDA the validity of the data source before we can use it. Okay, so now I'm going to provide more specific example for the GBS. As you know, GBS is very rare neurological disorders. So the background rate is about 5 cases per 100,000 person years, which means that we need a data source that's very large in order to be able to robustly evaluate the risk. We do desire generalizability of the data source. And for the vaccines exposures, are we able to use those vaccine codes to identify the vaccine exposures? And for GBS, we did literature search. There's a validated algorithm available to the codified algorithm that using diagnosis codes, which means that the accessing to the charts is not required. For longitudinal data, we need claims or EHR data sources. And data timeliness, we prefer a data source with short data lags. And also for prior use in post-approval safety study, yes, it has to be. So based on that, among all the candidate data sources, we ended up choosing Medicare, the fee-for-services one. There's no data source that's perfect, but for the Medicare data, it checks almost all the boxes except for accessing to charts. And it's not that we don't want to confirm the outcome, it's just for sponsor. We have restricted access to Medicare charts. And for the data timeliness, the Medicare that we have access to has about 15-month data lags. But still, based on all those pros and cons, Medicare is identified as one of the most fit for purpose data source for this study. For AFib, the considerations are similar, and here I'm only going to highlighting those differences that are indicated in purple fonts, which is AFib is a relatively more common event. So the requirement for the sample size is more modest. Because AFib, there's no established codified algorithm to ascertain these events. So we do require data source to be able to, we do require to have access to charts to confirm these outcomes. And based on that consideration, we ended up choosing the Veteran Health Administrations. And this data sources also is not perfect, but it checks the majority of the boxes. And then the only limitation is, as you know, veterans, over 90% of them are males. So which means if we use data sources, the results of the study will have limited generalizability to females. And based on that, okay, so then regarding the milestones, it's just briefly on this. The reason why I'm highlighting those 3 milestones is FDA mandates that the sponsor needs to specify those 3 milestones in the post-approval studies before the approval of the vaccines. And those include the final protocol submissions, the study completion, and also the final report submissions. And for the final protocol submissions, final that implies the protocol has been reviewed, endorsed by the FDA. So for sponsor that we need to put forward an appropriate and realistic timeline that takes into consideration the time for FDA to review, which could be slow sometimes, but also time for the sponsor to be able to revise the protocol based on FDA's comments. Study completions. So this also refers to the end of the study collections. So there's a couple of considerations go to when your study will end, such as what will be the sample size, the rate limiting sample size, the number of vaccinated individuals that will allow to minimally detect a pre-specified risk, such as for GBS from the literature, a 3-fold increased risk is meaningful. And also what's the projected adverse event uptake? It's a wild card. But we can reference that based on Shingrix and pneumococcal vaccines, in older adults, what will be the uptake, and then also bear in mind that the initial phase usually uptake is slow, and also time for chart reviews. And I don't have it here as a bullet points is the follow-up time, because for adverse events after vaccines, the risk window is usually short, like up to 42 days. But for a drug safety study, you also need to consider time for the follow-up for the events, such as if you have events as malignancies. The final report submission January is within 12 months of the study completion. So here, what I'm showing is based on the feasibility assessment and careful consideration of the timeline, those are the 2 post-approval studies that Pfizer committed to the FDA. And I know you're taking pictures, but this is all public information. I'm not sharing confidential information from, so you can find it from FDA's website. So, and all those correspondence. So that actually brings to the end of my presentation, which is the summary. The safety is an important priority during vaccine development approval. Post-approval safety research using real-world data is critical to further support the evidence base and public confidence for vaccine safety. And also have shared with you the important considerations for the planning of the regulatory grade and post-approval safety studies that include identifying the fit-for-purpose real-world regulatory grade data sources, and also the appropriate and realistic timeline. So that brings to the end of my presentation. Thank you so much for your attention. I'm happy to take questions.
Annette Regan, University of San Francisco. So you presented this really nice checklist for considerations for which data set might be the best to use in a real world data scenario. And I was just curious if, because it kind of sounded like every aspect was handled equally, whereas like some aspects of your checklist might be a little more important than others. So like I was a little surprised by the generalizability or the selection of veterans health data for atrial fibrillation, just given there could be sex differences and the outcome rate and things like that. So I'm just curious to know if you weight certain of these checklist items more than others.
Yeah, this is a great question. They don't weigh equally. They're all important considerations. For GBS, for us, because we know
It's a rare event, so the sample size, be able to robust evaluate the risk is more important. So that triumphs over the limitation with the Medicare data sources, which has a long legs. So I think the long leg is usually for the data source that we have access to, because I know for FDA, they have access to the more weekly Medicare data sources, but for the sponsors, the database access is more limited, that we only have access to the annual data cuts. So that speaks to that the elements we do not consider equally. In terms of AFib, we do recognize this as a limitations, but we think that the gender is more of like effect modifications. Whereas we'll still be able to robustly assess if the vaccine is truly related to AFib, but we're not able to look into the effect modifications. But also, I believe that there will be other post-approval safety study will look at AFib as well. So it's not just one single study; it's a totality of the evidence. Thank you. I'm nervous to get a question from the regulators. That's even better.
Have worked a lot with this. Yes, it's a very interesting subject. Something I have seen in the studies of yes, I have participated. I'm not saying I'm suggesting anybody do anything. I'm saying this is my experience. When you have a hierarchy of diagnosis, the positive predictive value was suggested the first diagnosis, as opposed to the 7 or 3/3, etc. The positive predictive value decreases dramatically. The problem with Medicare data is that the order of diagnosis in the claim is not hierarchical. So you will have to deal with that. The second thing is, in some studies I have done for H1N1, those international studies that we probably talking about, there was something interesting. This is just my opinion, based on what I saw. If the diagnosis of CBS is made by a neurologist, the estimate is more accurate in general. I'm not saying you have to do this or you have to do that. This is not the regulator. That's a fellow investigator. So what I mean is, if your case definition introduces some interesting algorithms, one of them is what is diagnosed by a neurologist. Medicare does have that information, the specialty of the provider. The other thing is, what's the treatment? Some treatments are so specific to GPS as opposed to other treatments. And the algorithm could be, I'm not saying anybody has to do it. I'm saying I like to be a little creative myself. And you can have a primary outcome and a secondary outcome. And the other question, and this is just a comment, one of the reasons to do a study is you found the signal during the clinical trial, right? That was not the case.
Yeah, so we call those as safety topics instead of calling them safety signals. To us, it's safety topics to be investigated. But just to respond to your comment regarding the PPV or how to identify GBS, I agree. And as we actually reviewed the studies that saw Medicare has been studying in the past for vaccine safety studies for GBS. And the validated algorithm that actually was generated from the Medicare and using the inpatient claims with GBS as a primary diagnosis. And that gives the PPV of, I believe it's greater than 70%. So we don't have access to charts to be able to confirm those GBS cases, but what we can do is to use those PPV to do a quantitative bias analysis to see how the result is robust after adjusting for the PPV.
Primary diagnosis, you know who diagnosis that you have to know the standard when you hide for primary.
Yeah, we'll talk offline. Thank you.
Well, welcome back, everyone. Sorry to cut your coffee break short, and hopefully in the next 25 minutes, I will be able to cover these topics. So this topic can actually be a whole semester course, but in today's course, I'm going to focus on common methods at a high level that are used in post-market vaccine safety monitoring in the general population. So here's my disclaimer. So in today's course, I will start with the two pillars for post-market vaccine safety surveillance, followed by selected statistical analysis using spontaneous reporting systems, and end with common epidemiologic study designs and design comparisons. And Bob actually covered this information a little bit in his presentation, but here I'm putting in sort of side by side. There are two key pillars for post-market vaccine safety surveillance. So the first pillar is passive surveillance systems, which rely on the healthcare professionals as well as the general public to report any adverse events following immunization. So to effectively manage the influx of the adverse events, expert causality assessment as well as statistical analysis such as disproportionality analysis are implemented to prioritize the safety concerns for further evaluation. And the second pillar is active surveillance systems, as Bob already mentioned, where a defined population are actively monitored for adverse events. These systems have several limitations, including selective collection and analysis of data, as well as these systems enabling confounding control, as well as a proper comparisons. So across these two pillars, the focus shifts from signal detection for hypothesis generation to signal verification for hypothesis testing. And this transition ensures a comprehensive and vigorous assessment for vaccine safety. So Joanne already talked about the limitations in the pre-authorization trials. And Bob also mentioned the importance of the spontaneous reporting system. So I'm calling your attention to actually the second box here, listed out the limitations in the spontaneous reporting systems when we are interpreting the results coming from these systems. So as I mentioned, so the spontaneous reporting systems are passive, and they rely on people reporting their post-vaccination experiences. Therefore, the spontaneous reports can be underreported or overreported. They are subject to reporting bias, inconsistent data quality, as well as inaccurate estimation of population exposure. The analysis that use the spontaneous reports also have limitations, such as limited adjustment for confounding, as well as lack of comparable comparators. Disproportionality is a common statistical reasoning that are used in the spontaneous reporting system to triage adverse events for further evaluation. So the term itself derives from the combination of proportional and the negative prefix dis, implying a status of out of proportion. So this happens when the observation is far from the expectation, either by seeing too few or too many.
So the expectation depends mainly on the following three factors. So first, how many people get the adverse events in general? Is the event common or rare? Second, how many people receive the vaccine? And lastly, what is the reporting rate? In other words, are people likely to report their adverse events? So the idea behind the disproportionality is to estimate what you would expect if the vaccine and adverse events are co-occurring by chance. So once we have the expectation, we can evaluate the observation in the context of observation. So the comparison we can evaluate the observation in the context of expectation. So once the comparison between the observed and expected is called disproportionality analysis. And this slide shows how to calculate three disproportionality measures. So the left table shows a the left shows a 2x2 table with input for the calculation. And I wanted to mention that different systems may use different exposure comparators. So for example, the EU passive surveillance system, EVDAS, uses any other medicinal products, while the US system uses any other vaccine products. On the right, I'm showing you three different disproportionality measures, including relative reporting ratio, proportional reporting ratio, as well as reporting odds ratio. As you can see, the calculated expected slightly differently. However, it can be proven mathematically that these three measures always point to the same direction. Either they're all above 1 or they're all below 1. So in general, observed to expected ratio greater than 1 tend to suggest disproportional reporting. However, additional requirements may be used by different systems, such as the minimum number of reports or a higher statistical threshold for signaling. Here, I also wanted to mention that the ratio greater than 1 does not necessarily prove a causal relationship between the vaccine and adverse event. So it could also be explained by other confounding variables, such as concomitant medication or comorbidity in the patients that could trigger this event. And we mentioned the several limitations in the spontaneous reporting system. So active surveillance system can actually address some of these limitations using a two-stage strategies with a serial combination of different study designs. So the first stage I'm showing here is near real-time surveillance or rapid cycle analysis, often using sequential testing. So essentially, this method is a screening tool to identify large increased risk of adverse events of special interest while data are accumulating. For example, the rapid cycle analysis was used by US government agencies for H1N1 vaccine safety monitoring in 2009 and 2010, and has been routinely used for the seasonal flu vaccination. In this course, I'm going to focus on the 4 study designs as shown in the purple box. So I will talk about more details in the later slides. The second stage involves epidemiologic studies with comprehensive confounding adjustment. And in this course, I'm going to focus on self-controlled case series, case control risk intervals, which have been extensively talked about actually by Hector. And I will end with concurrent cohort design. And obviously, there are other study designs such as case-centered analysis, case control design, tree scan that have been used in vaccine safety monitoring, but I'm not going to cover those due to the time limit. And before I go to the next slide, I want to mention that although this two-stage paradigm has been commonly used for vaccine safety, signal identification and evaluation, a recent method paper published by Mark Schuster's group reported that using self-controlled case series alone across the 2 stages actually gained more sensitivity for signaling compared to a historical cohort design followed by the SCCS design. However, they did not evaluate the combination of other study designs or the impact on time to signal when the data only partially accrued. So I provided a reference in the backup slides for those who are interested in reading more. So here illustrates the concept of the historical cohort design in the near real-time surveillance. On the right,
it shows a cohort of individuals who recently received a new vaccine. The aim here is to identify a comparable group in the historical data in absence of this new vaccine. The key aspect here for comparability is similar health-seeking behaviors. And for the historical cohort, it can be indexed on different dates. For example, it can be the vaccination date of another vaccine. It can be the date of the healthcare visit or an arbitrary calendar date. So in the case of a new flu vaccine, the historical cohort might be anchored on the vaccination date of a historical flu vaccine. However, in the cohort for COVID-19 vaccine, the historical cohort might be anchored on arbitrary date. Again, a recent method paper published by the Odyssey group, they reported that background rates were highly influenced by the choice of the index date, and anchoring on the healthcare encounter yielded higher incidence compared to a random date. And this is especially true when the risk window was short. So when we are selecting the index date as well as a historical cohort, a careful consideration will be required to balance the sensitivity for signaling as well as the comparability of the two cohorts. Lastly, I wanted to mention that this study design does not address the period confounding factors due to the nature of the design. The second design I'm showing here is a vaccinated concurrent cohort comparator design. This was recently used in the rapid psychoanalysis for COVID-19 vaccine by the US Vaccine Safety Data Link, or VSD. So as everyone here is aware, the COVID-19 pandemic underscores the importance of period confounding, such as viral circulation, community immunity, and changes in healthcare utilization, in addition to the uncertainty of vaccine uptake in the early surveillance period. So the diagram we're looking at here demonstrates the general idea of the study design. Essentially, it only includes people who were vaccinated, and we compare the incidence rates of the event that occurred in the risk window to the rate of the outcome in the control window on the same calendar date. Essentially, the analysis will be organized in risk sets anchored on the dates of the events. Obviously, this design will be able to address the period confounding. However, there are also some limitations, such as the limited number of cases in a control window in the early surveillance period, as well as a potential depletion of susceptible individuals in the control period. And another concurrent design resembles actually the matched cohort design that Morgan previously discussed. However, instead of looking at the effectiveness outcome, this design takes several look at the data while data accumulate to evaluate whether there is an increased risk of a predefined adverse event of special interest following immunization. So in essence, we will match the vaccinated individuals with unvaccinated individuals on the calendar date. And the unvaccinated individual will have the opportunity or will be allowed to be vaccinated at a later date, thereby establishing a new index date. Although, again, this study design is going to address the period confounding. However, it has a high requirement on complete vaccination information, as the misclassification vaccinated as unvaccinated might mask a potential safety signal. The last design I want to mention here for near real-time surveillance is the self-controlled risk interval design, which Hector has talked about extensively for vaccine effectiveness evaluation. So essentially, there are several use cases were published for febrile seizures and anaphylaxis following immunization. The risk and control windows were kept relatively short to minimize the waiting time for the data to settle in a control window in order to initiate the analysis. And I wanted to mention that this study design can also be used in the second stage for signal verification, which I will provide another use case in the later slides. This table summarizes the strengths and limitations of the 4 study designs I just discussed. I also provided some references and brief notes for sequential testing statistical methods, which provide the framework for sequential testing of data cuts at a predefined cadence as data accumulate. So in the following slides, I will focus on 3 study designs commonly used for signal verification. The diagram here demonstrates the concept of a standard self-controlled case series design, or SCCS. And I wanted to mention there is a comprehensive book by Farrington and others on this topic. So and if you're interested, if you're interested in this topic, you can read more. But here in brief, I wanted to mention that this design uses information only from cases or individuals with adverse events. The diagram here is demonstrating the gray bar is demonstrating the observation period, and the design and this study design estimate the relative rate of an adverse of an acute event in the predefined risk window post-vaccination, with all the other time as shown in blue in the observation period. And the rate ratio of the outcome essentially is based within person comparisons rather than between person comparisons. So consequently, the time varying confounding is implicitly adjusted for. And I wanted to mention here that the inclusion of the unvaccinated events are not essential, as shown as a bottom, because these cases do not contribute directly to the estimation of the vaccine effects. However, they can contribute to the estimation of the effects of age or season, if that's of the interest of your research. On the right, I'm showing you 3 key assumptions for the standard SCCS design. When the last 2 assumptions are violated, namely event-independent exposure as well as event-independent observation period, there are extensions for SCCS design to address these 2 violations separately. So there are several modifications that have been applied to the standard SCCS design, given the limitations in the administrative healthcare data, as well as the assumption of violations. First, only include vaccinated individuals to account for misclassification of the exposure, as the administrative healthcare data might not completely ascertain the information on vaccination. And secondly, only include the post-vaccination control period to account for reverse causation. So for example, if the occurrence of the outcome affects the probability of the subsequent vaccination, including the pre-vaccination control period, might bias the association in either direction. And lastly, if you are using the billing codes to identify the case, washed out the pre-existing cases might add the confidence in capturing incident cases, as shown as the long peach bar here. So on the slide, I'm presenting a use case of the SCCS design, and this study was published in JAMA and used the Danish register to investigate the association of febrile seizures following the hexavalent combination vaccine. So for each case, again, the observation period depicted in gray was divided into the risk period, 0 to 7 days post-vaccination, and the control period was defined as the other time, as shown in blue. The relative risk of febrile seizure was estimated through the conditional regression model. Here, I wanted to mention that the authors also conducted a sensitivity analysis by excluding 2 weeks prior to vaccination to address potential delays in vaccination due to either febrile seizures or general illness. And the sensitivity analysis returned a similar results as a primary analysis. And moving on, the self-control risk interval SCRI design is a special use case of SCCS. Since Hector has discussed about this topic extensively, I'm going to skip this slide to get to my last slide because I'm running out of time. But I just wanted to mention, I also added a reference. I also referenced a use case here for those who are interested in reading more. So lastly, I'd like to discuss a concurrent cohort design here. So if you recall, the match cohort design in the near real-time surveillance can also be used for signal verification in a second stage. But here I'm presenting you a slightly different use case that essentially treated the vaccination as a time-varying confounding. So for all eligible children, they enter the cohort at the start of the follow-up, and they move down to the exposed cohort on the day of vaccination, and then they will stay in the exposed cohort for 8 days, and then return to the reference cohort until the day of the next vaccination. The assumption here is that the risk of febrile seizure is transient, and the risk will revert back to the reference level once the rest period elapses. And the second assumption here is the occurrence of febrile seizure do not preclude the subsequent vaccination. And some may wonder, actually, there might be informative censoring or selection bias occurred if the second assumption was violated. However, it's not likely in this analysis, as the author demonstrated that the results from the cohort design were consistent with the results from the SCCS design, with or without the exclusion of the pre-exposure period. However, in the case of informative censoring, there are other methods available to address this, such as inverse probability of censoring estimation. And this is my last slide. So it summarizes the strengths and limitations of the 3 study design I just discussed for signal verification. And that concludes my presentation. Thank you.
You made a proposal for a variation of the self-control of the experience. When we go back to that slide 15, I think it's interesting to go back to it because this is what the original design, right? And then what you are suggesting here, in a way, approaches the self-control, the self-control risk interval. So would you like to comment about that? Because I find it
Thank you for your comments, Hector. Maybe I was not clear in my presentation because I was running out of time. So these variations would not be my proposal. Actually, these variations were used in the published studies. So these are people have been applied, but I would caveat this with the validity as well as the performance and potential biases related to these variations have not been comprehensively assessed. But these have been used in the published studies, even ongoing studies by the government agencies.
When we use self-control to do that, I have not self-control. But at the end of the day, I think that what the closer we get to self-control interval, the safer we. Many of the assumptions of self-control do not do type. We have just one event, and I mean, the follow-up periods should be short. Because we have one event probably for the same variant. Probably we only have one event, unlike the active infection. The second thing is about whether the follow-up can be interrupted by, let's say, mortality. Well, if you only accept the one event and there is no second event, and you have your outcome in the first window, regardless of whether the patient die or not, you can still go count the data, both windows, because there is no opportunity for the second event. What I mean is, the self-control is interval all vaccine safety 1% safety. That's how to overcome some of the restrictions, limitations proposed by self-control,
Yeah. Thank you for your comments. Obviously, there are pros and cons for this 2 study design. So for SCRI design, right? So because the shorter control interval, you gain more advantages in terms of less susceptible for time varying confounding. But the flip side is because you have a shorter control interval, you're more likely to be restricted by sample size in the case of rare events. And going back to the comment about if an event is highly fatal, so that's going to violate the third assumption for the standard study design, right? So the event independent observation, because of the occurrence of death, so the observation period will be prematurely shortened. So in this case, an extension of SCCS design is actually available, actually proposed by Farrington's book. And their most recent paper, actually I provided in the reference as well, is there is a there could be a small tweak in their original proposal, because the original proposal, you have two separate extensions to SCCS design to address these two assumption violations separately. But most of the time, they actually happen hand in hand. So they actually just recently published a paper to add some additional tweaks in the model to actually address these two assumption violations together. So in this case, the SCCS design with the consideration of the assumption violation could potentially add to the sample size, especially for the rare event safety monitoring. But again, because of the longer observation period, we have to consider whether there are time varying confounding compared to the SCRI design. So it could add to the more complexity by gaining the more sample size.
Okay, well, thanks. Good afternoon, everyone. I'm Annette Regan. I am a PhD epidemiologist and an associate professor at the University of San Francisco. And I spend a lot of my time doing large observational studies of vaccine safety and effectiveness in pregnancy. So most of my research funding comes from NIH. I do some consulting with Pan American Health Organization and CDC, but I have no conflicts of interest to disclose. So I'm going to talk to you today about some of the unique challenges that we tend to see when we want to do large vaccine safety studies in pregnant people that are brought in from the field of perinatal epidemiology. I'm going to mostly focus, there's a lot of issues, but I'm going to mostly focus on the biggies, the temporal issues that get introduced. And I will leave you with not just problems, but some solutions that we tend to use. So we know monitoring vaccine safety in pregnancy is becoming increasingly important. We have a long history of immunizing with inactivated influenza vaccines, and we learned a lot from the 2009 H1N1 pandemic when we had an intense vaccination campaign in pregnancy. We have over a decade of experience vaccinating with Tdap or other pertussis-containing vaccines. And then we know with the COVID pandemic, we had a rollout of a novel vaccine. And about a few months into the vaccine campaign, we saw prioritization in a number of countries of vaccination in pregnancy. And we know big news this week. On Monday, the FDA authorized use of the Pfizer's RSV vaccine in pregnancy, and there'll be a lot of vaccine safety monitoring in this population there. So we heard at the start of this session that we do have RCT, and that would be RCT data, and that would be the ideal scenario. But there are a lot of issues in this population. In some cases, we don't have RCT data. Pregnant women were excluded from trials. And then also we know that RCTs tend to have smaller sample sizes. They're not designed to be powered to detect differences in obstetric events. And also some of those less common obstetric events like stillbirth, it's very unlikely that a trial would have to be very large to detect differences in that. So there's a very big growing role for observational real-world studies looking at vaccine safety in pregnancy. Okay, so the way that I like to think of this is we have all the same problems as any other field. So all of those challenges that anybody in pharmacoepidemiology would have, like what kind of exposure window are we going to use? who's going to be an appropriate control. We have to consider all of that. But now we're overlaying these additional challenges that we face in reproductive and perinatal epidemiology. So we have issues with truncation, depletion of susceptibles, time-dependent exposures. I'm going to talk a bit about immortal time bias. And really, I think this just creates this double whammy. So there's a lot of additional challenges that we face when doing observational studies in this population. So the first problem is that this is a dynamic population. Thankfully, we are not pregnant forever. At any given moment, 5% of women of reproductive age are pregnant. The gestational length can vary. The typical pregnancy would be 40 weeks or 280 days, but we know we see a lot of variation there, ranging from 22 to 28 weeks, all the way up to 42 to 44 weeks. And we know this population is constantly being replenished. So we have new conceptions constantly entering our cohort, and we have births, which ends the pregnancy period, and they leave the cohort. And we also tend to see this seasonal pattern in conceptions and births, where we see births peaking in August to September months and a trough at April to May months. So this creates a bit of a moving target. And then in particular, early pregnancy can present a lot of challenges. We see a lot of attrition in the cohort over gestation. So it's estimated that fewer than half of fertilized eggs will make it all the way to a live birth. And we know even among pregnancies that are detected, around 16 to 20%, or our best estimate is 16 to 20% will end in spontaneous loss before 20 weeks. So we end up seeing this severe cohort attrition between conception and birth. And if the people who are included at the beginning of this period are different from the people included at the live birth end, this can create some bias. There's also been talk about concern around depletion of susceptibles, which is a cohort-based phenomenon where a drug exposure early in the follow-up period creates a depletion of the susceptible population, which shortens the follow-up time. So we end up seeing this pattern that we see down here, where there's an increased risk at the beginning of the follow-up period. And then due to this depletion of susceptibles, we see a stabilization of the risk or potentially a decrease. And most data sets that we tend to use in observational studies of vaccines and pregnancy are based on births. So this would be like birth registrations or large perinatal data collections. These include typically all live births seen in an area as well as stillbirths, but they are based on the pregnancy end rather than the pregnancy start. And so this has the potential to create some fixed cohort bias. And so we can see two scenarios here. We have pregnancy A and pregnancy B, which look pretty similar. They're in similar length, covering a similar time, but the only difference is pregnancy B happened to end after our time 0 and pregnancy A didn't. So we're going to include one and not the other. And then I think possibly even more problematic is our truncation at the right end, where we have here pregnancy C and D in the red lines, where pregnancy C and D look fairly similar, except pregnancy C has not delivered until after time 1. So the only difference is that one gave birth a week later than the other, and we're not going to see pregnancy C at all because they're not going to be captured in our birth database. So this can create this right truncation in our cohort. So selecting on the date of pregnancy ends up oversampling longer gestations at the beginning of the study period, and we oversample shorter gestations at the end of the study period. And thankfully, this is a pretty easy problem to fix. We can resolve this by selecting our cohorts based on LMP or some other estimate of pregnancy start, rather than selecting based on the pregnancy end. So for example, we could choose to exclude anybody with a birth with an LMP that was more than 20 weeks before the start of our study period, and exclude anybody with an LMP less than 43 weeks before the end of our study period. So this ensures that we're capturing the entirety of the pregnancy. So things get even more complicated when then we overlay this with temporal aspects of vaccine rollout and seasonal vaccine campaigns.
So we know COVID is a really good example, recent example of this. So starting back in March 2021, we had just one country that was recommending COVID vaccination in pregnancy to all pregnant individuals and 10 permitting. And over the last few years, we've seen a global expansion of the number of countries recommending. So now as of August 2023, we have 121 countries now recommending COVID vaccine in pregnancy and 64 permitting vaccination. So we do need to consider these vaccine availability periods when we're designing our cohort study with pregnant individuals. So here I'm using the US as an example. We started to roll out COVID vaccine in December 2020, and the policy for pregnancy would have been that it should not be withheld. It wasn't proactively recommended, but it shouldn't be withheld from pregnant individuals. And then in July 2021, ACOG and CDC proactively recommended vaccination in pregnancy. So we see these two different policy shifts. And based on when we overlay this with our fixed cohort issues, we can see that based on a few different scenarios, so we have pregnancy A wouldn't be included at all because they weren't pregnant during vaccine availability, which makes sense. Pregnancy B, we start to see their early pregnancy doesn't overlap with the vaccine availability period, but their later stages do. And then we have pregnancy C where part of their pregnancy overlapped with when it was permitted. So it would have been mostly high risk or very healthcare seeking individuals getting vaccinated versus the end of their pregnancy where maybe they were a little more proactive about getting the vaccine because it was recommended. So again, we need a factor for the vaccine policies, which may not exist at various stages of pregnancy or may be different at different stages of pregnancy. And we've seen this in previous examples from the H1N1 pandemic. So this is a really nice study that was done by Gabriela Vasquez Benitez at Health Partners Institute. And they were interested in measuring the association between H1N1 pandemic vaccine and preterm birth. And so here we can see, so the x-axis is the study week at the LMP for the participants. And so for the unvaccinated, we see a fairly even distribution of LMPs. But then we can see at the early stages of the study, it's mostly people getting vaccinated late in pregnancy in third trimester. And as the study progresses, we start to see people vaccinated in second trimester and then earlier in first trimester. So we see this shift in the gestational age of vaccine receipt. And we also saw this similarly in the recent pandemic with COVID-19. So here you can see the distribution of COVID vaccines. The y-axis tells you the gestational age in days that the vaccine was received, and you can see there's little, you can't see my cursor, but there's little lines to show you first, second, third trimester. And we can see for dose 1, when it was initially rolled out, so these are data from Ontario, and they recommended the vaccine in pregnancy in May. So you can see this real clustering around May 2021. But you can see it's really concentrated in the later stages of pregnancy. As we move to dose 2, we start seeing things spread out a little bit more. And then when we get to dose 1, which would have been a booster dose, we can see people, it's not uncommon that people would receive the vaccine in early pregnancy. So again, seeing this gestational age shift as the vaccine rolls out. So why does this matter? So again, going back to this example from the H1N1 pandemic and Gabriela Vasquez Benitez's paper, we can see that if we don't account for differential temporal access to vaccines, it can bias our effect estimates. So here we can see after they adjusted for temporal access to H1N1 vaccine, we see an effect estimate a lot closer to the null. So if we don't account for this, we will see a downward bias in the effect estimate. And it's particularly pronounced in third trimester, where we can see in the unadjusted model, the relative risk was 0.63. So it induces this protective association. So another challenging temporal issue is immortal time bias. So immortal time bias typically happens when we assign people to a treatment group or we measure an exposure status after time 0. And this can create this time period where an outcome actually can't occur, inducing this immortal time. So if this period of immortality is either misclassified or somehow excluded from this study, this is also going to bias our results in favor of vaccination, so create this protective association. And so going to our ideal scenario, which is always that gold standard randomized controlled trial, we don't have this issue because we have alignment at time 0 and everybody is aligned in terms of both calendar and gestational time. But in the real world, we know that that almost never happens. We don't have alignment of treatment allocation at time 0. So we end up with this unexposed immortal time, which can bias our results. So using an example, if someone gets a vaccine at 22 weeks of pregnancy, they could not have miscarried at week 12. So this creates this immortal time bias issue. And again, going back to the H1N1 example, they also considered how not adjusting for time-dependent vaccine exposure or immortal time bias would have influenced results. And again, we can see compared to the unadjusted model, we see an increase in the effect estimate or an approaching to the null. So if we do not account for this immortal time bias, we will see a downward bias in our measure of association. And again, similar to temporal axis, this tends to be concentrated in vaccines received later in pregnancy in 3rd trimester. Okay, so how do we fix this immortal time issue and other design issues in pregnancy studies? So first, because vaccination in pregnancy is a time-varying exposure, we need to handle it accordingly. So really, any method that can handle time-varying exposures would be appropriate. And one way is to allocate individuals based on their gestational timing that they were unexposed and exposed. So we can do this using an Anderson-Gill data structure where we actually create an observation for each gestational week. And we look to see if they were exposed or unexposed. Or we can do this by separating individuals into multiple observations based on their unvaccinated time or their vaccinated time. And then just to point that COVID threw an extra little issue here because this was the first time we're actually dealing with a vaccine that has multiple doses. So in this case, we also need to factor that into our time varying assessment of vaccination status in pregnancy. So we may need to create additional levels in our data structure to factor for receipt of 2nd dose and 3rd dose. Another option would be to exposure match. So here you can see we are matching an individual who was vaccinated at 16 weeks with an unvaccinated individual that was available at a similar gestational time point. And we probably would also want to match based on calendar time as well. So this allows us to align that time 0 in our vaccinated and unvaccinated groups quite well. In a final option, which there was a really nice paper recently published by Sonia Hernandez-Diaz, which proposed the use of target trial emulation. So using a hypothetical RCT when we're approaching or designing our observational studies is a very attractive option because we know the target trial is going to respect the basic principles of trial design in terms of the treatment assignment, the eligibility requirements, and the start at our time 0 is going to make sure that time 0 is aligned in our exposed and unexposed groups. And we know based on the earlier parts of what I discussed that misalignment of these things is going to introduce bias. So I'll give you one example, a recent example by Dr. Deshane Fell, who's in the audience. It was a really nice paper recently published in BMJ Medicine, which was interested in looking at the birth outcomes following a booster dose of COVID-19 vaccine in pregnancy. And they took a target trial approach to the eligibility requirements in this study. The outcomes of interest were preterm birth and stillbirth, which are 2 outcomes which we know are susceptible to immortal time bias and some of these temporal issues. So the way they designed the observational study, this was using the provincial birth registry in Ontario, is they included all pregnancies in residents in Ontario that had an expected date of birth between the start of the booster program and within 40 weeks prior to the end of data availability. And this was to avoid that truncation issue that I talked about earlier. They had to have received dose 1 and dose 2 before their LMP, and they had to be booster dose eligible. So again, kind of just simply setting our eligibility criteria and our requirements for inclusion in the study to align with what we would have done if we had been able to do an RCT. So really nice application of the target trial. I'm going to close with thanking Deshane Fell for helping me in preparing some of these slides and materials. This was actually previously her part of the course, so I'm honored to be stepping in. I've also put together a couple different references, which I think if you're really interested in this space and want to learn more about some of these biases and how to handle would be really helpful. And I am happy to take questions. Mm-hmm.
So how are you managing that in case of those children with signal sometimes you have
Yeah, that's a great question. And another problem that we didn't talk about. So usually, and I know this is the case in the Canadian data, there's a way to link the mother and the infant through the actual birth record. And it's the same, before I was working in the US, I was in Australia, and we did the same thing. We would have a way of probabilistically linking mothers, and actually it was deterministic, sorry. Based on the birth record, we would know which infants were born to which mothers, and then we can probabilistically link all their health information through other available administrative databases, whether that be like hospital discharge data, notifiable disease data, or other sorts of records. In the US, where we don't really have that ability, it's a little more complicated. So I mostly work with claims data, and claims data I think are a lot more messy. So our linkage between mother and infant is much less perfect. So I would say almost all mothers and babies could be linked through these really nice registries in Canada and Australia and other places. In the US, in my experience, we're able to link somewhere between 50 and 60% of the infants. And this is because if we're using claims data, we're actually relying on the infant being enrolled in the healthcare insurance plan. And there's a lot of reasons why they maybe lost their insurance plan. Maybe the child was never enrolled. If they're insured by the father or other parent and not the mother's insurance plan, we end up losing the infant in that case. So we tend to see a lower percentage of records linked in that case. But that would be how we would link maternal and infant data using claims records. Mm-hmm. Thanks, Karina. That's a great question as well. So the question is around how do we, specifically early pregnancy, which I mentioned is problematic. And one of the things that we've done, I think this is where being able to complement with additional databases is really important. So I know we recently completed a study with Boston University where they have this very nice preconception cohort. And I think those preconception cohorts can be very useful for vaccine evaluation in pregnancy. So we were actually able to follow people from before they ever conceived all the way through the 20th week of pregnancy. And we just published that in Obstetrics and Gynecology, looking at flu vaccine and miscarriage specifically. So I think being able to tap into existing large cohorts like that is really useful, but it's not going to address all the problems that you raised. Like people that are in a preconception cohort are planning pregnancy, and they're not going to be anywhere similar to the 30 to 40% of people that don't plan their pregnancy. They're going to be much more healthcare seeking. So you still have some other biases there. Other ways that we've tried to capture early pregnancy, which again is not perfect. I don't think there is a perfect way, but I think the claims and EHR data are pretty good at that, because using various algorithms, you can actually pick up from first ultrasound and procedures like that. So we can, in contrast to birth registers and things like that, we can actually pick up early pregnancies. But again, even that's not going to be perfect, because we're relying on somebody coming in for an early ultrasound or some other procedure, and those people are going to be different as well. So I wish I had a perfect answer for you, but I feel like this is one of the challenges in this area that we don't have a perfect answer for yet. And we just need to try and tackle these issues using different databases and different approaches and comparing our answers.
Y'all made it. Congratulations. Well, almost made it, I should say. As you can tell, my name is not Leah McGrath. She could not make it to Halifax, unfortunately, and asked me to step in. You're not getting the B team. The subject of her talk is my full-time job. So rest assured. Like Dr. McGrath, I am an employee and a stockholder for Pfizer. I want to do a couple of things. First, just take a very high-level overview of real-world data. This has kind of come up sporadically, or has been in the background of almost every talk you've seen today. And what I like to remind people is that we often talk about EHR data or claims data, and that's how we'll characterize what real-world data are. But there's a number of other categories that are going to come up sporadically throughout the rest of these slides. So it can include omics data, genomics data in particular, which I will circle back to at the very end. Family history data, which often we characterize around clinical categories, but I like to remind people social history is also really important. So we've got a literature that suggests that exposure to childhood poverty, for example, can create really important gene-environment interactions for alcohol dependency. So folding that in is really important. And the same is true for the environmental data. So that can be, climate factors, but it also can be demographic factors or geospatial factors. And so I like to take a really wide lens in terms of what I would characterize as real world data. And it can obviously include other things as well. As we think about all of these different categories, the term Joanne used it, right, is fit for purpose. And also, I think you said regulatory grade too, which are these two, unfortunately, nebulous terms, I feel like. And I'm not going to touch regulatory grade, but at least in terms of how we think about fit for purpose, we see it as kind of the marriage of two things. And this becomes relevant for the vaccine case studies that I'm going to show you in a few minutes. Right. So on one hand, it's data relevancy. Do the data actually have what you need for a study? Is the exposure in there? Is the outcome in there? Is it representative, right? And really importantly, I think for a lot of our vaccines designs, is it longitudinal? So that's one bucket when we think through fit for purpose. The other is data quality, right? And we see all kinds of challenges around the reliability and validity of the data for both claims and EHR data. How uniform they are they even plausible, right? I've seen birth dates in some large databases from the 17th century. That can't happen. So we have those sorts of challenges. It can be really hard to understand the provenance of these data sets. So large EHR and claims vendors are pooling data from tons of different places. We often, rarely have a window into all of those different sources and what some of their limitations and drawbacks might be. But if you can kind of answer these questions, and I love the way Joanne kind of laid it out for her like specific cases, right? How you think about fit for purpose, you can kind of get to this place where you say, for a given context, these data are appropriate, they're relevant, they're going to help us answer the question. And I'd like to remind people that this is not sort of a single determination you would make for a data set, right? That it's very much question specific. So while the Medicare data may be fit for purpose for you, for one particular study, it may not be fit for purpose in a different context, right? I go through all of this to talk about this one bullet point, which is completeness. And this is this unfortunately knotty problem with vaccines, which is that finding complete high quality vaccine data in real world data is really tough, right? And there are a number of reasons why. The first is there's a bunch of different places we can get vaccinated, right? And the data systems for all these different places, general practitioners, pharmacies, employer clinics, they don't talk to each other at all, right? So where you get vaccinated has a huge impact on whether your vaccine will show up in one of the administrative databases that we have access to. People are getting vaccinated, not just at employer clinics, but at schools and universities. We saw this a lot with COVID. We occasionally see this with influenza as well. Mass vaccination sites, which I think we tend to think about for COVID, but with Mpox, we saw the same thing, right? Where folks are, public health departments are going out to community centers, youth centers, and running vaccine clinics in those spaces as well. And again, the data systems, such as they exist, are not well integrated, right? So we have all these different places you could potentially get vaccinated, and all of these different ways that that vaccine could potentially be paid for. Some are covered by insurance. Some people need to pay out of pocket for certain types of vaccines. With employer-sponsored vaccines, often there's no cost at all, right? Which is a great benefit if you're the one receiving the vaccine. It's a real challenge if you're the one trying to find that vaccine. And then finally, we have two really important government funding pools that are used for vaccines. So one is a handful of states, maybe about a dozen, are what we call universal purchase states. Right? And so they are buying vaccines in bulk, providing them to participating healthcare providers. And there very often is not a claim at all associated with that vaccine. The other is the Vaccines for Children program, where vaccines are made available to participating healthcare providers. And again, and that happens in non-universal purchase states, there may not be a claim associated with that vaccination event at all. Final point I will make, there's also a wide variety of ways that these are represented in claims or EHR data, right? From text strings that represent the vaccine type or the manufacturer, down to lot numbers, which we saw for COVID, for example. The CDC provides a crosswalk, file to go from lot number to NDC codes, but we see CPT codes, we see CVX codes. So even if you can find the vaccines, often what you get to identify, especially when you're talking about brand or formulation level data, which we would need for vaccine effectiveness studies, for example, can also be spotty. Final point I will make, that first gap, GPs and pharmacies, that exists in a lot of countries, not just the US. So we see this as a challenge in the UK. I believe this can be a challenge in Canada too, where these are like not well integrated databases. I'll stop for a second. What have we forgotten? Are there other spaces or other challenges you all have experienced in identifying vaccines in real world data? Or you're just totally exhausted at this point, right? One of the two. Yeah, so especially for the series, right? Trying to link all of them together can be challenging. And that is even more so true with COVID, because it wasn't just that people were receiving them different places, but now we're going to start seeing different ways of payment being used, right, for those doses. So very, very hard to find the first 2 doses in claims. Most of us didn't have to present an insurance card. That is a good thing from a public health perspective, right? So I'm not trying to lament that. But with the bivalent vaccine, all of a sudden we do start seeing, right, more claims than we saw for the initial 2 doses. So certainly a challenge. All right, a couple of hypothetical examples. Sam works for Amazon and gets his annual influenza vaccine at a company-wide event at his office or warehouse, although most of the warehouse workers are contractors. Sponsored by Amazon, insurance is not billed. So would this vaccine appear in claims? I see heads going no. No, it would not, right? Will it appear in EHR? Oh. Maybe. And I feel like most of my job is just telling people it depends. But unlikely is probably how I would characterize this. Unless you happen to have a local health system that is running those clinics. So not very likely, this is what I will say. So Sam is probably going to show up as unvaccinated in a large administrative database. And this is really important for the designs that were really nicely described earlier, because we're making decisions about who goes in which cohort based on the data that are available. Sam's got an influenza vaccine and no one in this room can see Sam, right, in terms of his vaccination status. Emily, 6 months old. Parents will know this is not a fun pediatrician's visit, especially if the flu vaccine is also available at that time, right? She is in Vermont, which is a universal purchase state. All those vaccines that are given at her pediatrician's office, are those going to appear in claims? People are shaking their head no. The actual answer is maybe. The reason why is Vermont requires that even for participating healthcare providers, so not all providers participate in this, but even for participating healthcare providers, they have to do a $0 or 1 cent claim for vaccine administration that is supposed to include the CPT code. How often does that actually happen? Unclear, right? So the answer is maybe appears in claims. Other universal purchase states treat this differently. So it's very much state specific in terms of how they are processing these claims and what they require of providers. Some states, for example, vaccines for children, allow vaccinators to charge an administration fee that can be billed to Medicaid if the family says they can't pay. So like maybe it will show up in Medicaid claims, right? It can be really challenging. Will this appear in EHR? Yeah, absolutely, right? So we can get it in EHR data in a state like Vermont, but claims can be really tricky for trying to track pediatric vaccines because it is that universal purchase state. Finally, we have Diego, 67 years old, at a high risk for pneumococcal disease, goes to his local pharmacy, shows his Medicare card. Will that appear in his CMS claims? Yeah, right? Will it appear in his EHR? It depends, right? It depends who that pharmacy is affiliated with in particular, but maybe not is like the best way to frame that. So what type of vaccine we're talking about, where that vaccine was given, can influence whether claims or EHR are going to capture and represent that well. And again, it's so critical for these studies designs. And in particular, right, it's easy to find the people who have the vaccines recorded. It's really a question about who's unvaccinated. And are they truly unvaccinated, or do we just not know about their vaccination status? A couple of strategies, that we think about using as we're particularly early in a study, trying to assess data sources, right? Like how many people in a given data source can we find 1 or more doses of COVID vaccine in a given time period for, right? We take a similar approach with influenza, right? We try to figure out for the data source as a whole, what type of uptake are we seeing? How many kids have had that first DTaP series? And then make those comparisons to public data that we have. So for COVID, it's relatively easy because the CDC has been keeping these dashboards updated, sort of now. Harder for other vaccines, but the NIS, right, which is a long-running interview survey started in the 1990s, I believe after measles outbreaks, gives us a window into, are people in a community vaccinated, right? What should we expect meningococcal vaccine uptake to be how do we then compare it to our EHR or claims data? So these are strategies for thinking through fit for purpose, but they don't address the fundamental challenges that I laid out before, right? And so there is a couple strategies I want to talk about as future directions for vaccines real world data work. The first is tokenization. If you're not familiar with the term tokenization, what it refers to is taking a raft, hopefully a raft, of different PII, name, address, date of birth, social security number, other pieces of information that identify, hopefully increase the probability identifying me as me. There are a number of different tokenization companies out there that will ingest that data, will create a unique identifier that functions like a social security number, though it's much longer, it's kind of inscrutable when you see it on a spreadsheet. And they can go into multiple different databases, tokenize those databases, and try to give you either a deterministic or a probabilistic, depends on the provider, link between my vaccine records, for example, and my claims or my EHR data. This doesn't just have real world data applications. So for example, we're seeing this also pop up in the trial space, where trials are interested in people's past vaccination activity. We're all terrible witnesses for ourselves, right? Like, did you get a flu vaccine last year? I'm guessing this group probably knows. Normal people may be a little fuzzy on the details, right? And so tokenizing, if we can get consent to tokenize at the beginning of a trial, allows us to link back to their claims or their medical records and hopefully be a little clearer about what type of vaccine history they might have. We're starting to see publications actually come out into the wilds that feature tokenization work. I won't belabor this point given the late hour today, but feel free to use these as a reference at the end. One of the places I'm really excited about tokenization happening is with states, or in other countries, not the United States, national vaccine registries. So each state has some form of what's called an IIS, or an immunization information system, that will collect information about vaccines administered in that jurisdiction, with a whole bunch of caveats that I will talk about in a second. In theory, this gives us a window to not just look at uptake or vaccine coverage, but also potentially run vaccine effectiveness studies. There's also clear policy implications for doing this, including targeted vaccination campaigns. This could be the gold standard for vaccine data. But right, I said there's all these like potential caveats with it that make it potentially more like fool's gold than actual gold. Registries have different rules. Different states require different vaccines to be reported. So there's only about a dozen states that require all vaccines administered in that state to be reported to the state. Even when that requirement is in place, we know there are pharmacies that don't participate. They're probably smaller pharmacies that are able to kind of fly under the radar. It's not a major chain. It's not a major healthcare system, but we know it's not perfect data, right? There are a whole other group of states that only require it for pediatric vaccines because they see it as a key part of their K-12 administration system in the United States. There can also be a lot of variation in terms of speed of reporting and then direction of data exchange. So this is important. And even when you're looking at EHR data, it's important to know about this. So some states allow what's called unidirectional functionality. So when the vaccine is recorded in the EHR, it's sent automatically to the state to be recorded in the registry. Some states have bidirectional functionality. So when you come into your PCP visit, your record gets updated with all the latest vaccine information, if your healthcare provider has paid for that add-on to their EHR system. So if you can limit yourself to particular windows, particular healthcare providers that have that bidirectional functionality, even without having access to the registry, you can leverage it, potentially knowing that those data would be a little bit higher quality in theory. Again, some citations that I will skip because of time. The last sort of future direction we wanted to highlight has to do with the absence of good testing data, right? And in particular, the absence of negative tests and positive tests. So wastewater epi is one place where this can play a policy role. It's not at an individual level for studies a useful strategy, but in terms of characterizing the degree of either presence or absence of infectious diseases, there's a lot of promise there. It is something that was widely used for COVID. The CDC has endorsed this national wastewater surveillance system. The EU is requiring member states to have disease tracking in place by 2025 if they do not already. How does it work? I'll spare you the gory details, but you can sample wastewater at a building level in the clean out. So there's like a little cap you can unscrew in your basement and install an auto sampler. This can be done at the manhole level, where the auto samplers are actually placed under the manhole cover, or it can be done at a wastewater plant itself. The challenge, and we see this with the NWSS data, is that different vendors test the data differently. There's not a lot of uniformity site to site. And so it can make it hard to compare, right, like what's happening in the wastewater in Halifax with what's happening in the wastewater in Prince Edward Island. There's some other strengths and challenges as well. So one of the things we like about it is it's not reliant on clinical testing or medically attended cases. Where there's barriers to care, we may get a faster signal for public health officials that something has changed in the amount of community transmission. And we can target specific places of interest, right, where there may be more vulnerable populations. Weaknesses, the most important one, not everyone sheds an equivalent amount of virus. So you can't look at a wastewater signal and say, that's equivalent to 30 patients or 1,000 patients. Could be one person, could be 10, very hard to tell. Not everyone has wastewater. This is true in the United States. I have a septic at my rural house. We have, in the developing world, very poor municipal wastewater coverage in a lot of communities. So this is not a one-size-fits-all solution. And then particularly in hospital settings, pre-treatment, lab settings, pre-treatment can really damage that signal that's present there. So again, we don't see this as something we would link to individual level data, but in terms of increasing the situational awareness we have of disease transmission in communities, it's just really interesting and novel tool. And we're going to start seeing this season influenza and RSV wastewater signal becoming more commonly reported in the United States, which is really going to kind of change, I think, the landscape, our understanding of both of those diseases. So acknowledgements, I'd like to thank myself for contributing to these slides, as well as my colleagues, Sarah Willis and Berta. If you want to get in touch with Leah, she's fantastic. There's her contact info, and I'm happy to answer questions on behalf of both of us. Now we can say you made it, so congratulations.
Thank you. That was a very good overview and a very triggering topic. I think
I'm sorry. Sure.
I'm curious to know in your experience with EHR data. I know that sometimes patients will self-report their vaccination status if they received it at a pharmacy and it didn't make it to the record for if they got it at work. Do you know how often when you didn't look at that, or then it is flat in the EHR record? Curious how useful that is, or how often that
Yeah, we've seen the flag present in like a data dictionary. We've seen real variation in how often it's actually available when you get into the data themselves. I think, for me, I'm more worried about the absence of the information than the presence. So like if it's there, certainly I'm thinking about, is this reliable data, right? Again, we're all terrible witnesses for ourselves, but it's the absence that I think, not that I'm staying up at night thinking about this, but like that's the piece of this that I think is the real challenge, is when there's nothing there, knowing that for a chunk of these people, right, their data are present. But the historical data, and it varies like by vendor, by healthcare system. Is this even an option? I've never seen estimates of like how reliable they are when they're present. And my guess is if we did find them, they would be very specific, like contextually specific, and not necessarily going to generalize to like how good these data are writ large. It's a great question though. Yeah. Mhm. Sure. Yeah, I think some of that has to do with the novelty, right? So you've got like a room full of skeptics, correctly so, and this really interesting new way of thinking about the world that's, copies per milliliter, which is not how we usually think about disease risk or transmission, right? And so I think some of this has been about showing that this new interesting thing is related to things that we can all, at least those of us who do this professionally, can all like wrap our heads around. What we know from COVID is that there's a lag between these two things, between wastewater signal and hospitalization. Maybe we're talking about 3 weeks, something around that space. It tends to grow and shrink though, depending on how many people are getting sick. So the worse community transmission is, the longer the gap, because it takes longer to get those lab results back. So like the degree to which I see that connection is going to vary based on where we're at in the pandemic. We're going to lose a lot of that though, right? Where that ability to make those connections. And I think this is the challenge for wastewater EPI moving forward for something like RSV, where we think there's less shedding in fecal matter, and we don't necessarily have that like lab test result to help us characterize the hospitalization, is to let wastewater stand on its own to a group of people who are skeptical about the utility of this, which is to say nothing of the like, so what question of wastewater, particularly in pharma, right? Which is like, so what are we going to do with this nice looking graph, right? Like, how does that inform much of anything? I think that's another challenge that you didn't ask about, but I'd really like to share, which is, I think answering the so what question is very clear for public health. It's very clear for public policy, at least to me. And I'm like a converted skeptic when it comes to sewage. I think it's harder as we think about the biopharma sector, like where can we use this and what's the most appropriate venue to do that?
So if you can either grab a seat up here, pull a chair up, or stand up here, so we kind of have like a set or something. Maybe you can get some help. Just don't stand in front of the there was one question at least submitted online, so I just wanted to see that and have that be our first question. You can sit, you can stand, whatever you prefer. Okay, so let's start with the question that was submitted online, which is, does the test negative design focus on severe disease as these patients have actively sought healthcare contact? And is there a list of diagnoses that would fulfill signs and symptoms following a potential infection? So I think they're looking kind of for a recipe for success, which might be a little difficult, but do you have an answer to this question?
So in the test negative case control study design, when the patient appear to the healthcare provider, the test should be independent of the severity of the disease. If those severe cases are getting more testing than those less severe cases, then we are introducing selection bias, because the test would be depend on the disease, and then would actually bias our vaccine effectiveness. This shouldn't be avoided, or it would actually bias the estimate. This is what we need to we want to avoid when we do test negative study design.
Okay, thank you. All right. So to start, I thought we could think about how, this fall we're expecting our new XBB 1.5 vaccines to be on the market worldwide. And, we've talked about various study designs and challenges today, but if your goal was to get data on vaccine effectiveness and safety most quickly to your shareholders, which study design might you recommend? All of you.
Really depends, but if this is a vaccine for the elderly, the largest database in the Western world is here. So you get quick accrual, particularly if there is compensation. Some vaccines are just Part D and they are more difficult to track.
Okay.
If it is for children, then you get into a more complicated scenario. We could discuss on many other sources. Yeah.
And just to add with Part D, that's about half of Medicare enrollees now have Part D coverage. So it's a big group. That's difficult to track.
And that's half of the fee for service, which is as 50% of Medicare. So we're talking about 25%.
Morgan?
I just wanted to add that it's also where we are right now in the pandemic or post-pandemic, wherever we are. It's how these outcomes are assessed and what outcomes we're specifically looking at. So is it hospitalization, which may be a little bit more straightforward and potentially we can do using Medicare or even a test name design, vision, or one of the CDC sponsored funded studies. But if it's a less severe outcome, like symptomatic SARS-CoV-2, that's going to be, I think, complicated because people aren't really seeking care as readily now for those types of outcomes. So there's a lot in that question that needs to be unpacked before we can,
There's always our answer, right? It depends. But it's just trying to have a starting point for the discussion. Do we have any other questions from the audience for the panelists?
I'm just going to add for the safety perspective, I think the study design and the choice of data won't be very different from the previous COVID-19 vaccines, because in this case, we really expect the changes, for example, citing the mRNA platform, right? So the changes are really the sequence of the antigens, but really we should expect to see a very similar safety profiles as the previous versions, which has been extensively monitored. But in terms of study designs, it should be very also similar to the previous ones. Essentially, you could also use this two-stage strategy, starting with a near real-time surveillance, at the time of the launch of the new vaccine, and then followed by a signal verification. In this case, if you're going to do the study in US, it's going to be a self-controlled case series, primarily because of the limitations in administrative healthcare data, like Chris rightfully pointed out. So most likely we're not going to have the complete information for vaccination, even we're getting into the post-pandemic era.
I'll just add to you, I think we're going to see more claims. And that
Excuse me?
more insurance claims,
yeah.
right? And that's going to be a change that, didn't at all will represent the primary series, but will for.
Well, let's just explain, because we might have an international audience, why it would be.
Well, at least in the United States, we will see insurance claims for the XBB vaccine if it comes to market.
Because the public health emergency measures have ended.
And so Congress is no longer buying, pallets and pallets of vaccine doses for us to distribute.
And that also means the price per vaccine is expected to be over $100.
Yes.
And so, we've had poor vaccination rates that might become, even worse.
Can I just add from the, is this working? From the pregnancy point of view, anytime we're rolling out a vaccine and pregnant women are eligible, we're going to see a bigger lag in the studies we're able to do, because not only are we relying on the data availability with the new vaccine data, but we also need a health event registered to indicate a pregnancy. So when, thinking back to the beginning of the pandemic vaccine rollout, pregnant women were the last population that we saw published safety data on. And so even though the active surveillance systems that don't have denominators are not great, they tend to be really important for special populations like that, where we can actually see it. We can at least monitor adverse events post-vaccination using VSafe and things like that.
Yes.
I generally tend to look at the much easier cutthroat route or something, right? So the first thing is outcome misclassification. Well, if you have a good case definition, I would rather sacrifice those obscure maybe cases and focus on the outcome that is the most specific. Same for the exposure. We talk a lot about exposure misclassification, but really, if somebody comes with information that this person has been vaccinated, it's very, very likely it has been vaccinated. Yeah. So there is specificity there. So try to look at vaccinated only studies in that case, for instance. Then for quantitative bias analysis, you need some information, at least speculative, on what the problems are, what's the specificity, what's the sensitivity, and then you can work with it. Because if you come from thin air and you have no information on the amount of bias, then the confidence interval will be entre 0 and 1,000. So it's not going to be. But it is useful if you have some information, and I think it's going to be more and more useful.
Yeah, just to add to Hector's comments, I think, like I mentioned, for example, in the active surveillance system, you have this two-stage strategy for signal detection and verification. So in the first stage, the idea is really to increase the sensitivity so that we won't miss any safety signals. So in this case, even there are potentially outcome misclassification, meaning that we label someone who did not have this disease as they have the disease, this is going to basically still be signaled in the system potentially. That's why it's important to follow up with the second stage, which is a signal verification stage. In this case, not only the confounding would be comprehensively adjusted, and secondly, it could allow for example, outcome validations through medical records, right? If there is access, like Joanne mentioned, for example, if there is no access to medical records, in this case, there could be validation studies published in the literature, which would report positive predictive value of sensitivity specificity. So using those results that could potentially guide the quantitative bias analysis for the outcome misclassification for safety. And speaking of exposure misclassification, I agree with Chris. So after the pandemic era, I think it's more likely, so the claims are more likely going to capture the vaccinated information. But regardless, there could still be some potential misclassification of the exposure. That's why it's also important. So when you are doing this signal verification, potentially you could have a primary analysis, for example, using self-controlled design, followed with, if you want to enlarge the sample size, could potentially be a cohort study design with a quantitative bias analysis.
Maybe to throw my 2 cents on what they said, I agree in everything being said. From my experience in some electronic medical records, for example, I used CPRD a lot for some of my prior research. One thing which improved the definition of the outcome or ascertainment of the outcome or minimize the bias is linkage of the GP record with hospitalization data, and also, if it is possible, linkage with prescription data and DAYS registries and other disease registries. And you might actually, try to capture the outcome of your interest if you be able to link, these sorts of data sets. The second one is I agree with Joanne that for some type of outcomes in the database, it is difficult, if you don't validate, the outcome to ascertain accurately whether the patient or the participant has the disease or not. If it is possible, it is advisable actually to do validation of those outcomes, whether it is ICD-10 codes or some registries use, some different read codes like in CPRD and SNOMED code in different other databases, and it's validating those outcomes first, and or use whatever validated in the in the literature is much advisable, so which increase or minimize the bias or misclassification.
People can't hear you.
No, I would like to emphasize on your point because it's very important. When you have high sensitivity but the lousy specificity, you are adding too much garbage. It's a lot of work that you get on you. If you have a specific case definition, focus on that, what you get will be real. Then you get into a much smaller problem, which is generalizability. And you can address that, but first find whether there is a problem, at least in a subpopulation. Then you have something to work with. You start with working with a huge, sensitivity and very little specificity, you are going to lose a lot of effort and never know what is real until you get to a highly specific definition. So I really agree with you completely.
Oh, Bob wants to, Bob, did you have something to add? We can turn it off.
Make everybody's lives a little bit easier going forward. What we're trying to do with writing collaboration case definitions, and for those of you who are not familiar with them, that in the vaccine safety domain, at least we have about 70 standard case definitions for AEFIs. But historically, once we developed them, we never had the resources to evaluate and improve them and update them as medical healthcare system changed over time. And so we're in the process of kind of converting them to digital algorithms, not just PDFs. And also we're trying to link up with folks with good databases as living, well, we're going to call them living laboratories, so that we can continue to update and improve them based on the latest healthcare system, coding systems, et cetera, and then figure out a way to share that in as timely a basis as possible, because currently we're kind of partnering with CEPI, the Coalition for Epidemic Preparedness and Innovation, so that they have a 100-day goal for the next emerging pathogen X. So with COVID, it took us 300 days from identification of the virus to the initial candidate vaccine. We want to cut that down to 100 days. And so in order to do that for safely for vaccine, we need to just speed up everything that we're doing in safety, digitizing it, making sure that the things are up to date and workable for different data systems ahead of time. So anyways, that's kind of our aspiration at the moment. Hopefully CEPI will continue to support us to get that done, and then to expand that to as many outcomes as possible.
Okay. So in our last minute, what was you'll have the final question? You're good? Okay. All right. Well, let's all give a big round of applause for our many volunteer speakers for today. Thank you all for coming, and thank you all. And this hasn't worked particularly well, but you can use the QR code to give us feedback on today, or use the formal ICP evaluation process. Thank you.